Can you all hear me?
Yes, hello.
Hello, I'm Dr. Shahla, and I'll be your mentor for today, for the next 10 days. It will be great if you all could please introduce yourself.
I'm Dr. Tencho. I'm from Bhutan. I work in the emergency department.
All right, that's nice. And is this your first attempt for PLAB?
Yes, this is my first attempt.
All right. And how far are you with your practice or your things? Like, how much do you know till now?
Since I work in the emergency department, I didn't get enough time to prepare, but I did some big topics such as cardiology, obs gynae, surgery, GIT, emergency medicine, and I'm about to do pediatrics. And then
Very
I did.
nice. You've done a lot. You have done a lot. So have you tried solving questions as well?
Yes, I do PLAB keys and then I go ahead with PLABable.
All right, that's good. That's
I
very
didn't
good.
mock. I did do one mock in the beginning of the thing starting.
Okay.
That's the only mock I did, and then I was planning to do mock after covering all the big topics.
That's nice. That's a good idea. So how do you find yourself so far? Are you doing good?
Yes. When I'm doing topic, I feel I know a little bit, but then as I keep on doing the other topics, I tend to forget the big topics, the other big topics. So that is something which is worrying me.
Okay, so for that, I will tell you that you need to do a lot of revision, at least 3 to 4 times before you sit for your exams. Okay. So the thing is, okay, let's have the other introduce themselves, and then we can have a small discussion how to approach the exam and how to prepare for it. So can anybody else introduce themselves? Dr. Asma, are you there?
Hi, my name is Dr. Naz. Hello.
Yeah, Dr. Naz.
Yeah.
You're from?
I'm from Pakistan.
That's good. And so is this your first attempt? Yes, please go ahead and introduce yourself.
Yes, this is my first attempt, and I have an exam on 16th of February.
All right, that's good.
And I'm currently working at a government hospital here.
So how good how's your preparation till now?
It's okay. I'll say it's okay. I just did it once. Now I'm doing mocks.
Okay, good. That's nice. That's nice. So anybody else is there who would want to introduce themselves?
I just have I just have a question. Can you please introduce yourself first?
Yeah, sure. I was just waiting for everybody to be there so I could introduce myself just once, not repeat myself. I'm Dr. Shahla Tehseen. I've just cleared my PLAB-2, got my GMC registration, and I'm also in MRCG Part 1. So I will be mentoring the PLAB-1 week calls or mock for next 10 days. Today is the free session, but we will be having an entire 10-day session in which we will be doing all the mocks. And as you all know that there are 180 questions in the PLAB paper, and we just have 180 minutes. So for what we basically try to focus on, okay, before going further, what I did is that I had attempted twice. I failed once and then I attempted the second time. But the second time was this, that I targeted that I should have at least if not more, but not less as well, like 8 to 6 minutes of an extra in my hand, so I could revise the topics that, you can never know the 100% of the question paper, right? So, but there are questions questions in the paper that you know that this could be this answer or that answer. You just lock up on the second two options at the end. So that is what my aim was, to have at least 6 or 7 minutes in the hand, so that I could revise the ones that I have circled, and I think that I could go back and have a look at that. So here again, our main goal is to give you the clinchers, tell you the pointers, or how to go about approach the question, so that you are able to do if you have 180 minutes and you have 180 questions, so you nearly have just 1 minute per question. So we want to decrease that 1 minute to the question. We want to make it till like about maybe 50 seconds or 45 seconds, and that comes with practice, and you know where to look into it. So that's what the main aim of this workshop is, to make you able to do it as much as possible, and as in as little time as possible, so that you don't miss out on questions, you don't miss out on the important pointers over there in the question. So this is all about it. And of course, revision. And once when we do the recalls, the big mocks, so in that way you will be able to identify or pick up the points that are important, through which you can make a diagnosis, or select an investigation, or select the other points to make a correct choice over there. Okay, am I clear? Any questions so far from anybody? Please, I need interaction with people to get a better understanding and give you a better delivery of things.
Yes, you are.
Okay. So, anybody else here to introduce themselves, or shall I start? All right, let's start. So, okay. All right, just give me a minute. I have to share my screen. All right. So, this is the first question. All right. This is from epidemiology. Okay. So this is what we are doing right now, is August Big Mock. Am I clear? Am I audible? Any problems anywhere?
No, you're going good so far. Thank you.
That's good. Thank you. Okay. So this is epidemiology question that you can see. So when you open up your exam paper, this is going to come onto your face. So what basically we do is we try to go about from here. What is this? Relative risk, right? So you have to know that you are supposed to do the relative risk over here. So this is a new drug. All right, it's a new drug, and its name is Zidane, and it is undergone clinical trials for prevention of ischemic strokes in patients with significant cardio artery stenosis. The trial looks at the incidence of patients with coronary artery stenosis within 20 years period. The following is the data obtained from the study. Now we have, this is a diagram in which we have number of patients developed in ischemic stroke is 5, all right, and the patients who were on Zidam were 5. Number of patients who developed ischemic stroke who were on Zidam, they were 5 who developed it and 95 who did not develop it, right? So total patients who were tested were 100. Now the other group of patients was the one who got placebo, and they were 30 who developed the disease and 90 who did not develop the disease. In total, they were 120 patients. So to move on with the relative risk, what we really need to do is first find out the absolute risk. All right, the absolute risk is the number of events in a treated or control group divided by the number of people in that group. So I have made a chart over here. Disease A, treatment group, okay, which are, for example, who were given Zidam, and they're the ones who developed the disease are the A group, and the ones who did not were the B group. Again, the control, that the placebo. The patient who developed the disease are C, and the ones who did not were D. So for finding the relative risk, we have to find out the absolute risk. So for that, we need to know the formula. So the first thing is absolute treated. This is the control group. The control group is the one where you have the disease, and then the one you add the total number of patients. Basically, here when you go for the first one, here is 120. So you are going to have this 30 divided by 120. So you are going to get the ARC. All right. And then we have to have the treated group, the patients who were given, or the group of people who were given Zidam. So the group of people that were given Zidam were 5. And the total, that is 5 plus 95 is 100. So 5 will be divided by 100. Right. So this is first we found out the absolute risk. All right. And then we went on and we did this formula, we applied this, and we got 0.25 at ARC. That's treatment. The people who got the people who were on the control group. I hope I'm not making it very confusing for you guys, but this is something that you would have to memorize a little. Am I making sense to you all?
Yes.
Any
Yes.
response?
Yes.
Shall I go ahead?
Yes.
Yes.
Yeah.
Okay, all right. Now the second is the ART. That is the ones who were given the treatment, in which we had 5 people who developed the disease, and then we had the total number of people, that is the ones who developed the disease and the ones who did not develop the disease. So this is 5 plus 95 again. So this we got as 0.05. All right. Are you all with me till here?
Yes.
Yes.
Okay, so now we will be able to calculate the relative risk. That was the main part of the question, that we had to find out the relative risk. So how will we find out the relative risk now? So the relative risk is ARC minus ART. That is the control group minus the treatment group divided by the control group. All right. Okay, so this is 0.2, which we found out over here. All right, and 0.05, which we found over here, and we divided them by 0.2. This is the control group. All right, and we got 0.8 as the answer. All right, and if you go on, so this is the question. So the answer would be E. Is this making sense to you all? Do you want me to repeat it? No, Dr. Anam, you will be able to calculate them without the calculator. Trust me on this. It is a little practice, and you will be able to do it. See, okay. The main thing that you need to know is know the formula for all of them. All right. Shall I move on further?
Yes, you can.
Okay, thank you. Please, if you guys don't understand anything, you could raise your hands or prompt me in between so that, you know, I can stop. I don't want to confuse you guys. All right. Okay. Okay. Now, next question. Next question is a 64. Now, again, what I want you to do is you to find here what used to be my approach is that you have to see what have they asked you first. Okay, diagnosis. This is what they have asked you first. All right, I am going from down. I'm not starting from here. All right, if you get this approach, then it is going to be a little easier for you to find things out. So here you have to have the diagnosis. So now you just went through it that there is atrial fibrillation, ventricular fibrillation, supraventricular tachycardia, first degree heart block, and ventricular tachycardia. You have these options. Now you see it's a 64-year-old man who's presented to the emergency department with sudden onset palpitation. He also complains of associate lightheadedness, shortness of breath, but denies any chest pain. And he seems to demonstrate regular rhythm with a rate of 180 beat, and there is no describable P waves, no P waves. Okay, and QRS complex is 120 minutes per second. So now, can you anybody can guess what it was? AFib, SVT. All right. All right. Okay, good, good. That's nice. Okay, good attempt. But unfortunately, this is a SVT, not an AFib. Yes, the AFib also is close by to SVT, the things that are there, but this is a supraventricular tachycardia, regular narrow complex of more than 120 beats per QRS complex is more than 120 meter per square, and no P wave. So you see there is no P wave here. Can we find a P wave here? No, there is no P wave. So there is going to be yeah. Anybody wants to say something? Yeah.
Yeah. I can't see the screen.
You can't see the screen.
Yeah.
Is it visible now?
No, I still can't see it.
Just give me. Everybody else can see it?
Yes,
I can see it. I can see the screen.
You can't see the screen either?
We can see. I can see it.
You can't see the screen. Is it okay if you can relog again?
Okay.
Because most of the people, they say that they can see the screen. Can you log in again? I can wait. Okay, because it's visible to most of the people. Okay, so okay, so now the complaint, what the patient complained was of palpitation, lightheadedness with tachycardia. Okay, and it's a regular rhythm between 130, absolutely regular rhythm at a rate of 130 to 120 beats per minute, and regular narrow complexes without P wave. All right. Okay. Am I making sense to you all?
yes.
Yes.
Okay, good, great. Now, and the narrow QRS complexes have narrow shape and normal T wave. All right. All right.
Yes.
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 Shall I move to the next question now?
Yes, please.
Yes.
Yeah.
You can.
Yeah. Okay, a little bit on the management, because this is something that usually does come in the exam. So I would want you guys to know the management as well. the first thing is the acute management. All right. First, we do the Valsalva maneuver, that is the carotid massage. Okay. If that is helpful and the patient doesn't have SPT anymore, so we hold it there. Otherwise, the second step is adenosine 6 mg, and you could repeat it to 12 mg, then repeat it to 12 mg. But if the patient is asthmatic, as mentioned here, then we are going to give that patient verapamil. And again, even if after repetition the third time as well, then we will give a electro DC shock. You might have a question stating that the patient had SBT, the Valsalva maneuver was done, it did not still abolish, the SPT didn't abolish. So what is the next step? So you will be given a choice of adenosine, either 6 mg or 12 mg. So initially, please, you will be going with the 6 mg and not the 12 mg. Okay, Dr. Aksa, I'll tell you how to differentiate between AFib and, sorry?
Yeah, shouldn't the third dose be 18 mg because it was last year in PLAB-1 6, 12, and 18 mg?
I just gave my PLAB-2 and it was 12 mg, and that's where I've checked again.
Okay.
The recommendation, it was 12 mg. So even I was
Sure.
confused, but that's where we get it from the PLAB-1 and from the GMC. It was 12 mg.
Okay.
All right. Okay, and if the patient is hemodynamically unstable, that is his blood pressures are going very low, then we do give the DC converter first. All right. Then next is prevention of the next episode will be beta blocker or radio frequency ablation. Fine. Dr. Aksa, I'm sorry. The thing is that I could share with you. Just a minute. You want me to give you atrial fibrillation? The thing is that you might be having okay, now this is it. You see, now the atrial fibrillation is here. Can you appreciate it? This is a very minute, I will say P wave available over here to us. Can you see? Can you differentiate between them?
Yes, it's difficult to see, but
yeah, I know.
Even-
I'll just try to make it bigger. Just a minute. Give me a minute. Just try to make it bigger. Is it now? Can you see it?
the
Can
screen
you-
doesn't change.
Doesn't change. Wait, I have to. All right. Now here you go. Can you see this now? Can you see this now?
Yes, but I can see
This
it.
is the fibrillation. This is the fibrillation now. The other thing, the rhythm is going to be irregular. All right.
Okay.
All right, fine. Again, in
Okay.
fibrillation, you do not have a P wave.
Yes.
All right. Hallmark is absence of P wave, but it is very different to SVT. All right.
Okay. Yes. Thank you. It's the major difference is like regular and irregular, I think.
Yes, exactly. Yes, exactly. The major difference is that. All right.
Oh, thank you.
Okay. Thank you. Welcome. Now, this is something I made a chart so that it is easy for you guys to see. If the patient is hemodynamically stable, Valsalva maneuver, that is the carotid massage, adenosine repeat rapid IV bolus. If not successful, then 12 mg, then repeat 12 mg, and again electrocardioversion. Somebody asked me about 18, so this is where I got my again. I mean, I did it. Look into it. All right. I'm moving on to the next one. I have a question. Okay. All right. Now the next question. A 39-year-old man presents to the GP. I would want to go like this again, so that even you guys get this into habit. of starting with what are they asking first. Now, again, here they're asking you for the diagnosis. All right. So see, here is the diagnosis. Now, you are given the options. Parodontist suppurativa, I'm sorry for the pronunciation, folliculitis, then impetigo, scropholoderma, then inversion psoriasis. Now, when you read these options, you make up your mind what they could be asking. You will know what folliculitis is. You will know what impetigo is. All right. Okay, these are something that, and you would know what psoriasis is. Now you're left with these two. All right, let's go on and read the question. This is a 29-year-old man, GP, presents to the GP, painful lumps in the armpits, groin, and back. Now, reports that the lesions presents have come and gone over the past few years, but have become more problematic in the past month. Examination. Now you have on examination tended inflamed nodules and abscesses in the man's axilla and genital area. Okay, and large lesion drain purpurine material. Why I'm skipping? If you notice, I'm skipping some on something like these, because when you are already doing your practice, you will know. Now, does anybody know the answer of this one? I mean, if you want, you can unmute yourself and tell me that you know the answer or not.
Folliculitis?
No. Okay, why do you say folliculitis? Do we have tender inflamed nodules in folliculitis?
It's option A.
No.
It's hidradenitis suppurativa, I think.
Sorry?
It's hidradenitis suppurativa. It can be folliculitis.
It could be folliculitis. Okay, fine. So I'll go with, we have this option A here. All right. Just a minute. Yes. Okay. Most of them are saying A. I'm sorry, I'm not a very good IT whiz, so I do make problems with the laptop and all. Okay, sorry. I think, can you all see it? The answer?
Yes.
Is it? Okay. All right. So these are the things I have. Just a minute. Okay. So hidradenitis suppurativa is a chronic follicular occlusion. All right. Now, again, it's a recurrent inflammatory nodule. So what we had over there is a question that it was reoccurring for the patient. If you remember, here he said it is present, lesions present have come and gone over the past few years. All right. And they were tender inflammatory nodules and abscesses in the axilla and in anogenital area are seen, right? So these again, they have sinus tracts. These are abscesses. They have sinus tracts, complex scar formation, right? And it causes lesions that are tender. Okay, malodorous. They didn't mention, but they could. And it is common in intragradous areas, the areas where they rub each other, like armpits, the groin areas, where the skin rub over each other. That's the area basically where they have the most. So armpits and the groin. That is what is mentioned. All right. Now, in inverse psoriasis, the lesions are usually macerated red patches rather than discriminated abscesses. In psoriasis, you don't have abscesses, right? Am I audible? Am I making sense here?
Yes, ma'am.
Oh, okay, good. Thank you. I would want to have an interactive audience, please. Okay, the next is scropholoderma. It is a cutaneous manifestation of tuberculosis. In this, you will typically have a history of travel, somewhere exposure, travel, and in tuberculosis, they would give you a history of travel to maybe India, Asia, and these are the places that you could have the history of travel, and then they would give it. I don't know if they would give it at the first thing. And these do eventually ulcerate, okay, with a granular base. So this is the picture, how it is going to be. All right. Now, as far as the impetigo is concerned, it is typically a honeycomb lesion. I hope it is visible to everybody. All right.
Yeah.
Okay. I have two questions. Okay. Thank you. All right. Let's move on to the next one then. Okay. The fourth one again. What are they asking you over here? It is the question of treatment. All right. They are asking you here the treatment. Now, when they are asking you for treatment, you would say you would have a very different thing. Now, just below it, you have clue cells. Where do we get clue cells? Now, you are trying to make up your mind.
Bacterial vaginosis.
Yes, very nice. So, in a way, you have already solved your answer, right? You've got the answer. You have saved about, I would say, about 40 seconds over here. So now again, this is a 28-year-old woman who is comes to a sexual health clinic. People are usually sexually active. All right, offensive smell, vaginal discharge. Recently started a new sexual relationship with a male partner. She denies any significant medical history, but is allergic to penicillin and antibiotics. Now, a speculum examination, what does that reveal? Presence of thin grayish white discharge. And microscopy confirms the presence of clue cells. Now, you said bacterial vaginosis. So what is the treatment of bacterial vaginosis?
Metronidazole.
That's good. That's nice. Now let's move on. So here is the answer. This is bacterial vaginosis and overgrowth of Gardnerella and loss of Lactobacillus species. The most sensitive findings on microscopy is clue cells. All right. So you will get clue cells. I guess I got this question in my exam. And the first line treatment is metronidazole. Now, bacterial vaginosis and trichomonas are very close to each other because they both have offensive smell. All right, and they both have a vaginal pH of more than 4.5. All right. And bacterial vaginosis has fishy odor, which is prominent, and they have clue cells and thin white or grayish discharges there. But with trichomonas, you have a yellowish discharge. All right. Other very important thing is that there would be a strawberry cervix. They would mention in trichomonas that the patient has strawberry cervix, or they would say that the patient had the cervix was very red and it elicted pain. These could be the findings over there. I've made up a small chart over here for you to have a look at it. We have already done trichomonas, and you know that about the pH as well. But when we come to candidiasis, this is what we have to look into. So the pH is going to be between 4 to 4.5. These are the points that differentiate between these three findings that are that is trichomonas, bacterial vaginosis, and candidiasis. All right, am I clear so far?
Yes.
Yes.
Yes. Just a minute, let me see the chart once. Yes, the penicillin is a distractor, definitely. You will get a lot of distractors. There will be something very close to each other. So yes, this is something you need to keep in mind. All right, let's move on to the next question now. Again, we will go with the diagnosis. What is the diagnosis? You have all this over here. Now let's move on further. 19-year-old student, emergency department with 3-day history of headache, rigors, and night sweats. Now, when you have night sweats, you would think about either malaria or you would think about dengue. All right, he has a recent return from a trip to Nigeria for 2 weeks. On examination, his temperature is 39.1 and all other observations are within normal. Within normal range. He has mild scleral icterus. Now, the white blood cells are low. Platelets is borderline low, I would say. Again, hematocrit is low. ESR is high. Sodium is normal. Bilirubin is a little high because the patient is jaundiced. All right. So, any answers?
Malaria.
Malaria. Very nice. Yes, it's malaria. Okay, so let's move on. Now, this is malaria. Plasmodium parasite and has a transmission from female Anopheles mosquito. Most common travel history, endemic areas. So now PLAB-1 has a little, these are called as clinchers, okay? So they would mention Africa for malaria. And then, of course, intermittent fever, rigors, headache, and jaundice. Now, what investigations we do for malaria is thick and thin blood films, most accurate, all right? And shows anemia and thrombocytopenia, which there was mild thrombocytopenia on investigations. All right, there was mild, just a little borderline. Okay, and now there could be an option if you are given an option that diagnosis. Sometimes what happened, I mean, I would have it this way that everything is given, and I know that next would be the investigation. Like they have diagnosis with malaria, so what will be the preferred investigation? So in that case, microscopy of thick and thin film is the most accurate investigation. All right, you will not go for a rapid diagnostic test. Here in Pakistan, when we have patients in the ER, we do rapid diagnostic tests. But normally, yeah.
Yeah, excuse me, I want to something that is this big mock you are solving?
Yes, it's a big mock. It's the August big mock. It's not the October big mock.
Okay, okay, thank you, thank you.
Okay.
August big mock to 2022?
Yes, exactly.
Okay, okay, thank you.
Okay. The next we'll be doing in the coming days. All right. Okay, there are a few clinchers that I wanted to tell you guys about. And the clinchers is, see, okay, so if the patient is presenting with malaria, there could be a travel history to Africa. All right. If the patient is presenting with the travel history to Far East, malaria travel history is to Africa. All right. And the dengue fever, the history would be Far East. If you can note it down, it'll be helpful. Typhoid would be South America, and then diphtheria is India. Okay. And for typhoid, there would be severe headache and diphtheria, flu-like symptoms. Okay, am I making sense, everybody?
Yes.
Okay, and for dengue fever, they could give you a travel history to like Bangkok, and there will be fever, myalgia, and arthralgia. And there could be also maculopapular rash, and there will be thrombocytopenia in that as well. Okay. Do you want me to repeat anything?
Yes, please.
Yeah,
Can you
please repeat what you
please?
just said.
Yeah.
Sorry,
Yes, please. Can you repeat it?
repeat it. All right, sure, no worries. So for malaria, they will be giving you a travel history to Africa. Okay. All right. For dengue fever, that could be Far East, Bangkok, etc. And they will be telling you that there is fever, myalgia, and arthralgia. All right. And along with that, there could be pharyngeal erythema. Again, there is going to be thrombocytopenia, mild or moderate. And then there's going to be maculopapular rash. Okay. Next is dengue Far East. Okay. Typhoid, South America. And for diphtheria, it would be a travel history to India. Okay.
Okay, thank you.
Okay, how would you differentiate if it is given a travel history? Travel history is usually given. If it is not given, then of course, then you would say that there will be body ache. Myalgia would be there. Arthralgia would be there. There could be a maculopapular rash as well. Right. So this is how we will differentiate from the other ones.
We also differentiated from the jaundice and the yellowish of the sclera.
Jaundice, you could have jaundice in malaria as well. As you see, this is written over here that the patient is icteric, right? Jaundice in both. Jaundice is going to be there in both of them. So even in dengue, because there's some thrombocytopenia, so there is a chance of having anemia as well, and so there is a chance of having jaundice in both. But in dengue, you will be having myalgia or arthralgia. Okay, shall I move on further?
Yes, please.
Any question? Okay. Okay, now next question. Again, we will go with what has been asked. Important intervention. Okay, hypertonic solution, IV sodium chloride, delivery by C-section, fluid restriction, and epidural. Okay, now what this is, a 32-year-old woman presents to the labor ward with regular painful contractions. She phoned the labor room yesterday morning with regular tightness, but was told to stay home, remain hydrated, and take paracetamol until her contractions become stronger. So she is basically in contractions since a day before, maybe more than nearly 24 hours or more. Okay. Now struggling with pain and is found to be 5 cm dilated on vaginal examination. This is her first pregnancy. So keep in mind, first pregnancy would take into 24 hours or maybe more. And in UK settings, we do not jump to cesarean section right away. All right. So now her routine fetal growth scan has been reported as normal, and there is no concerns about the fetal heart rate. So they're telling you that everything is normal. She is allocated a midwife for 1-to-1 labor care and is encouraged to stay hydrated and breathe through the pain. At 8 cm dilation, it is noted that she has reduced urine output and routine urea and electrolytes are requested. She is otherwise well. Now here her sodium levels are low. One more thing, let me make it clear that during in your exam, you will be given a normal levels. All right, so you really don't need to memorize them. Okay, so most of you have answered B. All right, let's see. Okay, all right, good. Most of you have answered B, right? Now let's see what the answer is. Basically, the answer is D. I'm so sorry. Even I would put it as B, that you will be giving her IVs fluids. What would be the intervention? This is dilutional hyponatremia. See, she has been hydrated. She was taking hydration, and oxytocin that is given during labor does work as ADH, so causes water retention. There is a lot of water in her body. Because of that, her sodium has gone low. All right, am I making sense here?
Please, can you
Yeah.
go back to the question?
No.
Yes, no, I couldn't get it. Can you be a little louder?
No, I said, please, can you go back to the question?
The question.
Yeah.
Yeah, here you go. Okay. So she has been hydrated. She was given hydration. So one reason for having a low sodium level, where you have the rest of them normal. So low sodium level is because there is a lot of fluid in the body. All right. So you will do a fluid restriction over here. If you notice that she has been under labor since a day before. Okay. Sorry, I couldn't hear if somebody's trying to talk.
Yeah, what about the reduced urinary output?
Reduce urinary output. See, this is again, see, the thing is that she is 8 cm dilated. Can you see this?
Yeah.
Yeah. So she and the movement is going on. The head might be moving, and because the descent of the head, the urinary output is decreased. Again, which could be pointing towards dilutional hyponatremia. Am I making
It's quite
sense?
it's quite a tricky question.
Exactly, it is. That's the reason it's in PLAB. Okay, so it is a tricky question, no doubt, but you need to make sense over here. See, you have to see that the sodium is low. This is hyponatremia. All right, and you see that the urine output is low, and you have to see that she has been kept hydrated since day before. So, and here again, she is being kept hydrated again. So because of that, there is dilutional hyponatremia. Now, is this all? Now, see here, we didn't go further. Urinary output reduces in labor and would not be an indication for IV fluid, especially in the context of dilutional hyponatremia. You could make it worse. So see, urinary output is reduced. In labor, yes, it is reduced because of the fetal movement, the movement of the fetal head. So urinary output does reduce. Is it making sense to you all now?
Yes.
Yes.
Okay, shall I move to the next question?
Yes.
Okay, next question then. Okay, we have the next question here. Okay, I'm really sorry, this is on the same page, answer is. So, okay, let's do it. This is, what is the diagnosis? I'm sorry, the answer is on the same page. So it's less of a trick here. Now, again, diagnosis, you have epidermoid cyst, abscess, liposarcoma, lipoma, and Hodgkin's lymphoma. I try to hide this, but I can't. I'm sorry, now you have seen the answer. Anyway, a 31-year-old woman presents to the GP surgery concerned about a lump on her left shoulder. On further questioning, it is non-tender and has been growing in size for the past year. She denies any trauma. Okay, on examination, 4 cm, skinned colored dougy and highly mobile. Subcutaneous masses. There is no central punctate. A picture is here. So this is the picture over here. Are you able to see the picture?
Yes, ma.
Yes, I can see the picture.
Yes.
Okay, so this is something that the picture is like. Okay, so this is a lipoma. It's a totally benign condition, and it is slow growing, soft and homogeneous lump, which is non-tender and is dougy. And like again, when you go with Hodgkin's lymphoma, which would be a second one, it does also have an enlarged lymph node, and it's firm and non-mobile. Okay. Okay. Let me check.
Yeah.
Okay. Any question? Okay. All right.
What about the liposarcoma?
Again, liposarcoma, you would have a history in the liposarcoma. Let's see if I can find for you liposarcoma. Just give me a minute. Just give me a minute. My internet is giving me trouble.
I think
Sorry?
it would include a history of weight loss and more like
Yes,
cancer-like
yes,
symptoms.
exactly.
Could
It
have
would
risk
include a
factors.
history of it. Yes, exactly. It would. Just give me a minute. My internet is acting a little funny right now. Just give me a minute. Okay. Let's move on to the next one. Are we clear on this? Okay. Can we move on to the next one?
Yes.
Yeah.
Now. Okay. this is a question about hemophilia A. All right. Now, in this question, and this is a very commonly asked question about these things. In this question, risk of fetus having hemophilia A. Now, a 32-year-old man and his wife attend the genetic counseling clinic. He's suffering with hemophilia A, and they are concerned about the risk of a future child having the condition. His wife is currently 10 weeks pregnant and is not a carrier of the hemophilia. Non-invasive testing has confirmed a female fetus. Now, what you have to do, basically, you have to make a chart over here. If you all, if anybody knows the answer, okay, good. Okay, very good. C and D, 25%. Good. All right. So I will move on to the answer now. So it is 0%. Why? If you see here, hemophilia is X-linked disease. Okay, it's an X-linked recessive. X-linked recessive means that both genes, like both of them has to have the disease for the child to have the disease, right? And it is carried by the X gene. Now, when the male has the disease here, hemophilia A, the boys don't take the X chromosome from the father. We all know that. So the boys take the Y chromosome. So here are the males. They are going to be the normal males. All right. And the females are going to be the carriers. Okay. All right. So the females are going to be carriers. So in this way, the answer is going to be D. The male child is not going to be a carrier, nor it is going to suffer from the disease. Am I making sense to you all?
Yes.
Great.
Yeah. Sindhu, and one more.
Yeah, sorry. Can you be a little louder?
Do we get an extra paper in the exam to do all the rough work, like the calculation?
No, dear, you don't get an extra paper in the exam to do the rough work. You have to manage with the paper you have, and trust me, you can draw on it. There's no problem with that.
Okay, thank you.
You're welcome. Okay, now the next question. All right. Now again, single most appropriate next step. All right. This is a 69-year-old man. Okay, has been assessed by the speech and the language team following a middle cerebral ischemic stroke. Prior to his stroke, he has no past medical history and took no medication regularly. It has been between the medical team and his family that due to his significant risk of aspiration, enteral feeding should be commenced via a NG tube. Now, the NG tube is inserted without difficulty, and gastric aspiration is taken, which demonstrate a pH of 4.2. Now, what is the single most next step? It is either we do a chest X-ray, perform a wash test, start enteral feed, abdominal X-ray, or pH of the gastric aspiration. Oh my God, I'm having a lot of answers here. Okay, chest X-ray. Why do we do a chest X-ray?
To check the position of the NG tube.
All right. Okay. In any other question circumstances, this would be the right answer. Okay. But here we will start with the enteral feed because the pH has already been tested. See, to check for the NG tube, the best and accurate method is the chest X-ray. Okay, but in some hospitals, as you would know that in UK, most of the hospitals, or I would say not hospitals, but trust have their own trust guidelines. So somewhere the pH is performed and somewhere they do the chest X-ray. Either of the two are the accurate ones, but if you have done any of them, then you can proceed with the enteral feeding. All right. So let's go on for the answer. So answer is C. See, option C. Start with the enteral feeding. All right, we have the option C, that is start with the enteral feeding. All right, now what is it? Once the NG tube has been inserted, check gastric pH. If the pH is more than 5.5, then request a chest X-ray, because then the pH is going to be, then there is a chance of aspiration. If aspirate is less than 5.5, then it is safe to feed if no other risk for falsely low gastric secretion. This is the policy from the National Patient Safety Agency. Always take NG tube to prevent aspiration pneumonia. So the most accurate test is chest X-ray. The NG tube should be in midline down to the level of the diaphragm, with the tip clearly visible below the diaphragm. All right. So the guidelines vary. Some hospitals do use the pH indicator strip as the first line, but chest X-ray is the preferred method. And then again, the wash method is not accurate. The method that we do is blow a bubble. Sorry, a little louder, please. Somebody said something. Okay, so assessing a bubble, like we put a stethoscope on the tummy and we just inject a bubble in air inside it. That is again not accepted, because the tummy could have air inside it. All right, so if you are asked about the most accurate test, and if you're given the option of chest X-ray and pH indicator, you're going to put, you will be selecting chest X-ray. And if you are already given the result, like in this question, so you will go on with the enteral feed. Okay, making sense here? All right.
Could you please go back to the question?
Yeah, sure. There you go. Okay.
Okay, thank you.
You're welcome. Okay, let's move on to the next one. Now, oops, again, I am very sorry. Just give me a minute. Okay, we have a next question. A 32-year-old, I'll just come to it, okay? Actually, sometimes there has been a bit. Yeah, okay, you are again getting the answer. I'm so sorry. A 32-year-old man is started on carbamazole for his active Graves' disease. 2 weeks later, he develops a sore throat and temperature with associated mouth ulcers. He was told that if he develops any of these symptoms, he should seek urgent medical attention. What is the single most important test to perform? Now, as you have already seen the answer, I'm really sorry for this again. Carbamazole can lead to neutropenia and agranulocytosis. So for that reason, we will be doing a full blood count. In a routine, these kind of patients have their routine full blood count regularly, about I guess 6 months. I totally don't remember the guideline that well, but in 6 months, yes, or in 3 months. And they have a routine blood test to see if there is any neutropenia or agranulocytosis. Okay. Any questions? Can I move to the next question, please?
Yes, please.
Okay.
Yes.
Okay, thank you. Now this. Okay, 81-year-old woman is admitted in acute medical unit following a fall with a long lie, that is straight. Okay. On examination, she is disoriented and confused. All other observations are within normal range. On further inspection, she has 5 into 4 cm area of non-blanching erythematous skin overlying her sacrum. Now, can you make the diagnosis here? What is this? It is non-blanching erythematous skin over the sacrum. Now, can you make the diagnosis? Just tell me when I can tell you the answer. Okay, shall I move on with the answer? Do you all know what it is? Okay, I have one. Right. Yes. Yes, it's C. See, it's a pressure ulcer because it's on the sacrum. Okay, and it is non-blanching erythematous skin. So it is first stage, stage 1. All right. Here you go. This woman is presenting with stage 1 pressure ulcer, which is non-blanching erythema of the intact skin. If it is stage 2 pressure ulcer, then there is partial loss of dermal layer. Pink ulceration is going to be there. Okay. And stage 3, full dermal loss, often exposing subcutaneous tissue and fats. All right. Then in stage 4, the full thickness ulceration is there, exposing bone, tendon, or muscle osteomyelitis may be present. Atrial and venous ulcers are not staged. All right. This is something that you need to remember. Atrial and venous ulcers are not going to be staged. You won't have stage 1, stage 2 in them. Okay. And again, they are not going to be present on the sacrum.
Okay.
Okay. Now here is a picture. Let's make it a little bigger for you guys so that you can have a look and have an idea. I'll just give you a message on that. All right. Shall we move on to the next one?
Yes.
Okay. 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 Again, I'm so sorry. Okay. This is a 32-year-old refugee who has been living with his family in a 1-bedroom apartment. He is a family of 7. His youngest child is 3 months old and his oldest is 13-year-old. He has recently been diagnosed with lung cancer. His family is concerned as he is only one working to pay the rent. Now, what is the single most appropriate team to refer to? This is going to be the social services. Okay, this is something that when you go through PLAB, you will understand their system of working. Where is the social services concerned? Because it is nothing about the safety. So no safeguarding team is going to be into it. It is about the social services because the patient is not able to pay the rent, make the livelihood. So the social services team is going to be contacted with. And there is no harm to the family as well. That is the reason the safeguard team is not going to be contacted. And what the social services team is going to do, because hopefully, inshallah, once you're done with PLAB-1, you will be moving on to PLAB-2. So these concepts about social services and safeguard team has to be a little clear in your minds, and the occupational health team as well, right? So the social services team is concerned where there is financial support is regarded, and the safeguard team is when contacted when there is any harm, like maybe domestic abuse or something like that. Then the occupational health team comes into play when you have a patient who's an elderly and she's living in a place where she's going to undergo a surgery, and you have to see that how is she going to move about in the house. So that is where the role of these 3 people come into play. Now, palliative team again is going to be a team that is going to look into a very sick person, very sick individual who's admitted into the hospital or who's going to be taken care at home, and the palliative team is going to come and look about them taking care of their daily routines like their medications, their feeding and all that. But that is usually done in the hospice in the UK. All right, am I making sense here? Shall I move on further?
Yep.
Yes.
Okay, thank you. Next. Now again, this is what is the approximate area of this burn? Okay, this is some question regarding the burn. Okay, all right. Now, a 45-year-old man is brought to the ER department suffering from severe burns whilst throwing petrol onto a bonfire. On examination, his he has burns to his entire left arm. Now you need to develop a picture in your mind that what his left arm, I'm sorry, my drawing is not that good. So his left arm is burnt, all right? This is burnt. Entire aspect of his left leg is burnt, because you have to make a percentage, okay? Please don't, and the entire torso and the genital area. So this is the front part, all right? So all this is of his is burnt. So what will be the percentage? Why do you need to know the percentage of the person of for the burn? Because you need to administrate the fluid to that burn patient, and we do that by the Parkland formula. So have you got your answers? Okay, let's see the answers. So it is E, that is 37%. Now, if you remember in the question, it was stated 90% of the arm, okay? Now, entire left arm, okay? Entire left arm was burnt, okay? Anterior aspect of the left leg was burnt. If you go to the question, if you want me to go to the question, anterior aspect of the left leg, entire left arm, okay? And anterior chest, 9%, and his anterior abdomen and 1% of the goes for the genital area. Okay? Are you guys with me? We are going to have a long evening today, or morning, whatever you people are having, in whatever time zones you all are. Okay, I will try and make this a little bigger, so that's easier for you all to have a look at it. Okay, is it can you appreciate it now? Everybody?
Yes. Yes.
Now see, now let's start. Here it is the entire left arm. Okay, so this is the left arm, entire. So front and back, both. The front is 4.5% and the back is 4.5%. So both of them together, you get it 9%. All right. So entire left arm is 9%. Okay. Anterior, then you have anterior aspect of left leg. So anterior aspect of the left leg, this is again 9%. Okay, this is 9%. Okay, then you have anterior chest. Anterior chest. Okay, and for his anterior abdomen, now you have here 9%, here 9%. Okay, so you have 18% here, and 1% is the genital area. So you have 37%. So is this making sense to you guys?
Yes, yes.
Or what if forearm is burnt and arm is spared, how much percentage would be? They're giving you the entire arm over here. Don't confuse yourself. The forearm and the arm. So because they won't be giving you that much of a complicated question. They could see for the palm and the hand is just 1%. Okay, so they normally don't give you such confusing questions. Okay. Part of the limb, like see, if they could say that anterior or posterior. Okay, so if they have anterior limb, or they could say like see the entire limb anteriorly, the entire limb anteriorly, or the entire limb posteriorly is 9%. So if they say, for example, they say lower limb, the forelimb or the upper limb, then it could be 4.5%. But this is something very confusing, so they won't be asking you these kind of questions. They try to keep it very simple. Okay, so now why do we need to know the percentage? Is because we need to give the patient fluid, and we give the patient fluid with the Parkland formula, which is body area burnt in percentage into weight in kgs, and 4 ml use Hartmann solution. Okay. So far, I haven't seen a question where you have to put in calculated, but you might. So please keep this formula handy. What you need to know is that you give half fluid requirement in the first 8 hours and give the second half over 16 hours. Okay.
Yes.
Okay. Shall I move on to the next question?
Yeah.
Okay. 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 Now we have this question. Now, this is a patient. See, we have to, we see that there is an ABGs done, and we have to find out if this is type 1 respiratory failure or type 2 respiratory failure, compensation is there, acidosis is there, or alkalosis is there. Okay, so now we go on with the question. Believe me, trust me, when you are going to sit for your exams, your eyes are going to be here when you open the question paper. You won't be having your eyes over here. Okay, now a 67-year-old man with chronic obstructive pulmonary disease, that is COPD, presents to the A&E with worsening shortness of breath for the past 3 days. Okay, he denies any fever or worsening cough, but his sputum has changed color from gray to green. And arterial blood gas is performed. The pH. Now, see, you have the normal values here, so you won't be needing to memorize them. Now, pH is 7.2. Normal is this. Partial pressure of oxygen 7.4. Normal is this. Partial pressure of carbon dioxide is this. Then this is bicarb over here, and okay, bicarb is there at 30 millimoles, and this is a normal pressure. Now you need to find out which kind of a respiratory failure is this. Now, when we look into the arterial blood gases, the first and the foremost thing that we see into is the pH. All right. Now, this is a pH of 7.2. So from the pH, we know that it is acidic. Now, next we move on to see that either it is a metabolic or a respiratory. Okay. Now, next we are going to see how is the partial pressure of carbon dioxide. So his carbon dioxide is high. Okay. So this seems to be respiratory. All right. But when we see here, when we come here at the bicarb, so the bicarb is also increased. So this means that there is the bicarb gives you a metabolic picture. Okay, that is alkalosis here. All right. So we see that the bicarb is high. That means it is a compensation is going on to counteract on this partial pressure of carbon dioxide. All right. Now the partial pressure of oxygen is low. Okay. Now, do you seem to make a picture over here? Yes. Yes. Compensation is going on. Ramin, yes, you're right here. Okay. All right. Okay. Okay. Let's move on to the answer then. So the answer is A. Why? This is type 2 respiratory failure. Okay. This is type 2 respiratory failure with respiratory acidosis. Now, one thing, let's talk about it. In type 2 respiratory failure, you have to look into 2 values. Okay. Here it goes. Here in type 2 respiratory failure, low partial pressure of oxygen, we had a low partial pressure of oxygen over here, is 7.4. Okay. And we have a high partial pressure of carbon dioxide. Okay. And we had a high partial pressure of carbon dioxide. Although there was thing going on with the compensation as well, but it is not a compensatory respiratory acidosis. So C is not going to be the option here. It is going to be A. Okay. Yes. As oxygen is low, so it's type 2.
Sorry, please can I ask the question?
Sorry?
I want to clarify something.
Yeah, go ahead.
Since there is a compensatory mechanism going on there,
Hmm.
why are we now choosing A as the answer?
We are choosing A as the answer. You mean to say, why are we choosing A as the answer?
Yes, why is A the answer since there's a compensatory mechanism going on there? Because the respiratory acidosis has already been compensated. There's a metabolic compensation of the respiratory
Yes,
acidosis.
yes. If you look
So
into every, okay, I'll tell you. If you look into the option C, it is compensatory respiratory acidosis. There's no compensatory respiratory acidosis. There's compensatory metabolic alkalosis. You see here.
Okay.
Okay. Because bicarb always tells you about the metabolic parts, not the respiratory part. All right.
So in exam, if we see compensated metabolic acidosis for something like this, that should be the answer.
Metabolic alkalosis. That is going to be
Yes,
compensatory
yes.
metabolic alkalosis.
alkalosis. Yes,
Yes,
metabolic
that would be
alkalosis.
the right answer. Yes, exactly.
Okay.
Okay. Yeah, just give me a minute. Okay. Yes, it is partial compensation, not complete compensation. Okay. Now here, one more thing. In type 1 respiratory failure, just look into one value. That is partial pressure of oxygen, which is low. And PCO2 is either low or normal. So it is type 1 respiratory failure. But here we have type 2 respiratory failure and is characterized by two things. It's type 2, so you look into two values, partial pressure of oxygen and high pressure of carbon dioxide. It is classically seen on COPD and neuromuscular disorders. The blood gas shows partial compensation due to kidney reabsorption of bicarbonates. It is not fully compensated as pH is not normal. So if you have a full compensation, and so far I have never seen a question like that. If I have, I don't remember, but I've never seen a question telling you that there's full compensation. The pH is never into a normal, because if the pH is normal, then you won't be able to make a diagnosis. All right. Can we move on to the next question?
Yeah.
Okay. Okay. Now, again, what is the diagnosis here? So when we see that there are many things, so we can see that we have cholangiocarcinoma, hepatocellular carcinoma, hemangioma, Wills disease, gallstones. Now, it's a 60-year-old man with long-standing history of liver disease, liver cirrhosis, secondary to hepatitis C infection. All right. Presents to the GP surgery with vague abdominal pain and noticeable jaundice. On further questioning, he noticed that his clothes have been fitting more loosely and he has had to buy a new belt. On examination, you note ascites. Okay. Yes. Most of you are right so far. Okay, let's move on. So this is hepatocellular carcinoma. In hepatocellular carcinoma, aggressive tumor that occurs when there is a setting of a chronic liver disease. So this patient had a chronic liver disease and liver cirrhosis. Hepatitis B viral infection, chronic hepatitis, that is hepatitis C, infection, hereditary hemochromatosis and cirrhosis. Almost any cause will increase the risk of hepatocellular carcinoma. Typical clinical features of hepatocellular carcinoma are right upper quadrant pain, jaundice, this patient had, ascites, early satiety, and weight loss, because the person said that he had bought in a new belt and clothes were loosely fitting. Okay. So anything that has chronically going on would lead to cirrhosis. all right, will lead to cirrhosis, and then it eventually will lead to, I don't know if you can see this picture. Can you see this? Any chronic problems like hepatitis B, C, alcohol, anything, any chronic hepatitis would lead to cirrhosis, and then early hepatocellular carcinoma and advanced hepatocellular carcinoma. Okay.
Yeah.
Can we move further?
Yes, please.
Okay. Oh God, again, I'm so sorry. I don't know why I've done these mistakes here. Okay, now this is an 11-year-old boy with cystic fibrosis, regular performs postural drainage. Okay, he continues to have recurrent chest infection and is smaller than that other boys in his class at school. He was diagnosed at birth via newborn blood spot test, that is heel test, heel prick. And cystic fibrosis is caused by a mutation in cystic fibrous transmembrane conductase regulator gene. And the gene is, you have all seen the answer, is 7, chromosome 7. Okay, cystic fibrosis questions do come a lot in the exams, and they ask you a lot of questions in cystic fibrosis, and it is in which you would be asked about not stunted growth, he's married or he has a partner, is not able to have a baby, so they are also infertile. Okay. Okay, so let's move on to the next question.
Yeah.
Okay. Now again, causative agent. A 29-year-old woman presents to her GP with sore and itchy spots in her armpits. She is otherwise well. Examination reveals multiple papules and pustules in the left axilla, which are mildly tender to palpate, and short armpit hairs. No lymphadenopathy. Folliculitis is suspected. All right, you have folliculitis. On further questioning, the patient reports going to a party a week ago where she used a hot tub. Okay. Now, if you all can understand get the answer. Okay, Reem and Saida. Now, yes, this is stuff. Or yes, some would also go with, Pseudomonas aeruginosus. Some might say, because this is a hot tub mentioned here, so they might go with that. But this is folliculitis. Also, folliculitis is an infection of the hair follicles, characterized by pustules and papules, which may be itchy or burn. It's most commonly caused by Staph aureus. Okay. However, in spa facilities such as hot tubs, infections often caused by Pseudomonas aeruginosus as it thrives in warm water. All right.
Mommy.
Okay, can I move on to the next question now?
Yes, please.
Yes.
Oh God, again. Okay, fine. Now, this is a little tricky question here. I don't know why I got this. Okay. A 47-year-old woman presents to her with a history of increased thirst and frequent urination. BMI is 34, and she has a family history of diabetes. Urine that reveals glucosuria only. Type 2 diabetes mellitus is suspected. Which of the following should be consistent with a diagnosis of diabetes mellitus? Now, this is a very important question in regards that you will be asked about these things. This is a pretty direct question, and you could be asked about these questions indirectly as well. So here you're given a fasting plasma glucose level of 6.1. All right, but it should be more than, as you see, it should be more than 7.1 for the diagnosis. Okay, next will be just give me a minute. My thing is running out of charge. Okay. Okay. So see, for fasting blood glucose has to be 7.1, 7.0, sorry, for the diagnosis, or 2-hour plasma glucose concentration has to be more than 11.1. Okay. Or HbA1c has to be 48 or 6.5%. All right. HbA1c of 50, that is 6.7%, would be consistent with type 2 diabetes mellitus. Okay.
Okay.
So you need to know these values. These values are important because you will be asked in either of the ways. All right, I'll keep the screen for a while so that you can note it down. Okay, just let me know.
Just a question.
Yeah.
Isn't one value of HbA1c, if the patient doesn't have the symptoms, right? And you just test the patient's HbA1c and it's more than 48. So you will require another HbA1c level or not?
Yes, yes. If the patient is asymptomatic, you will require another another test with after a week or 15 days.
Of HbA1c, right?
Yes, if it's
It goes the same for fasting blood sugar and HbA1c. So if the patient is symptomatic, you just have to do one level, and if the patient is symptomatic, you have to take 2 levels.
It's asymptomatic, you take 2 levels. If yes, if symptomatic, this one is enough. Okay, and again, sorry.
But HbA1c is like it's giving you the value of the last 3 months. I don't think repeating it is
No,
necessary.
with HbA1c you won't do that. Yes, sorry, with HbA1c you won't do that. But you will not start with them on immediately on medications. You will start with lifestyle modifications, and then I guess after 3 months you will repeat the HbA1c again. You will see how they are, and then you will, if need be, then you can go on to next level of giving them metformin, depending on the patient again. Okay.
Okay. So if it's HbA1c, you just rely on one value. It doesn't matter if the patient is symptomatic or not. But if it's fasting blood sugar, you have to do it twice if the patient is asymptomatic, and you just do it once if the patient is symptomatic.
Yes. Again, if you have a patient, you can come across a scenario in which they would say the patient has some illness or was hospitalized and things like that, and the fasting was high. Whatever the value would be high. So will you start him on lifestyle modification? Would you repeat the test, or what would you do? So in that case also, you might not need to repeat the test. There could be an option, because I remember that kind of a question coming in. You don't need to repeat the test, because when a patient is sick, there can be hyperglycemia as well. Okay.
Okay. Yeah. Infection causes hyperglycemia. And this. Okay, and this is a mock test, or is it August PLAB exam revision?
It's a big mock August.
So these questions were in August PLAB exam, right?
I am not very sure of that. What we have is just the August mock, the big mock.
Okay. Okay, thank you. This is E.
Okay. Now, this question that we have right now. This was some scenario that came to me for my PLAB-2 exam. Okay, now it reveals, now again, you have to make a diagnosis. This is a very small scenario. The patient has macrocytic anemia. Now, when you see the macrocytic anemia written here, you know there are 2 reasons for macrocytic anemia: B12 and folate deficiency. So you really mark these off. Okay, you really mark these off. All right. So a 60-year-old man presents with a 6-month history of gait disturbance, recurrent falls, and paresthesia. He also complains of tongue swelling and redness. Blood test reveals macrocytic anemia. Okay. So most of you have given me the answer as A. Who is this with the iPhone? Who wants a 20-minute break? I'll see if I can, because we have really need to do okay. So we'll see if we can do 20 minutes break in a while. Okay, we haven't still done 20 questions. So okay, so the answer is yes, E. The patient most likely has vitamin B12 deficiency, which causes symptoms like glossitis, that is inflammation of the tongue, paresthesia, ataxia, as well as macrocytic anemia. Now, folate deficiency in UK is rare. Okay, it often coexists with vitamin B12, and there is a considerable overlap between the symptoms of vitamin B12 deficiency and folate deficiency. Glossitis can occur, but neurological symptoms such as paresthesia are more typical of B12 deficiency. Okay.
Excuse me.
Okay.
Excuse me, how long is this session for?
We're going to try and solve as many questions as possible. And Cecil, where you can go on with us.
So do we have any target in mind?
Okay, the people who are asking for recordings, they will be having, we will not be covering the whole questions today. They're basically August Big Mark. There are 180 questions and we won't be covering the entire questions. I think I just need to confirm for how long this session is going to be. Okay, and okay, we won't be covering the whole questions. Okay. Shall I move on further?
Okay, thank you. Yes, please.
Okay. Okay. Just give me a minute. Somebody was asking me about doing a break. So what about doing about 30 questions and then taking a break? Is it okay?
Yes.
Okay, so we'll do up to 30 questions and we'll try and complete about 90 questions for today. And then nearly about 90 questions. And then we'll finish off for today. So as soon as I'm done with 30 questions, so you get a good idea of approaching a question. So, and a good idea how I am going along with you guys as well. So we'll take a break after 30 questions. All right.
Okay.
Okay. Thank you. I'll move on to the next question. Now, this is a pretty much obvious question. A 19-year-old woman attends a dinner party with friends, and she is informed by the organizer that she is allergic to shellfish. But due to mistake, she receives a meal containing crab. She develops severe facial swelling and difficulty breathing shortly after starting her meal. Okay, she recognizes this as an allergic reaction. So now when you have an allergic reaction, you know that, but she has not brought the EpiPen with her. What is the single most appropriate action on arrival of the paramedics? So do you know the answers? You want to make an attempt? Okay, Saida, A. Something A. Yes. So do you know after how long do you want to repeat this? And would we be giving hydrocortisone as well? Okay. So this is to be repeated after 5 minutes, and hydrocortisone or steroids are not recommended in the management of anaphylaxis. Okay. Shall I move on to the next one?
Yes, please.
Okay. Thank you. Now, this is a 6-month-old infant brought to the clinic by his mother with the concerns of oral thrush. Now, when you are in the exam, you will definitely have a look at the oral thrush if you have been revising. The infant has a white patch on his tongue, so you know that the child has candidiasis, right? That cannot be wiped off. He pulls away from his mother while breastfeeding. He's fully breastfed. His mother has no burning of her nipples, and her nipples are not cracked. Now, what is the single most appropriate management? Here we know that the child has oral thrush over here. And so what will be the management over here? So can you all make guesses? Put in an answer. Okay, this name has A. Why mother, Tehseen? Because mother doesn't have any problems. B. Hira, B. Samsung, B. All right. Okay. See, this is the clincher here. Both mother and infant has to be treated because reinfection or oral thrust can occur if the mother's nipple are not treated with antifungal cream. Why? Because see, the child is having candidiasis, all right? So when the child is having candidiasis and he's suckling the mother, so he is going to transfer the infection. All right? So, and there is no need for doing a culture of the milk or a skin of the nipple as results are often negative, even though thrush is present. Okay? Are we clear on this? I think Hira told me that, no, Hira said, okay, A. Misha said A, and somebody else also said A, and that is the time I said why, because the mother doesn't has the infection. But yes, you will be giving them both because a child could be transferring the infection to the mother. Okay, can we move on further?
Yes, yes.
Okay, thank you. A 54-year-old man presents to his GP with difficulty straightening of his little finger. It has been worsening over the past years, but denies any pain. He is now unable to fully straighten the finger. On examination, there is a triangular puckering of the skin of the palm, and a firm nodule is palpable at the base of the little finger. What is the single most likely diagnosis? Okay. Okay. Okay, that's good. Trigger finger. Okay. Mm-hmm. Okay. The answer here is B. This is Dupuytren contractures. Fibrosis is shortening of and shortening of the flexure tendon of the ring and the little finger. This leads to a flex deformity. So if you see the question here, he's unable to fully straighten the finger. So it is flexed, right? So it is, okay, this leads to a fixed deformity. It is not reducible compared to trigger finger, which can be snapped back into place. There is going to be sound when you try to straighten that in a trigger finger. So it is not a trigger finger. It is a Dupuytren's contracture. Okay.
Another thing to add, also there is puckering of the skin of the palm, so
Yes,
which is very much diagnostic of Dupuytren contracture. So it can't be trigger finger for the people who were answering trigger finger.
Yes, can't be trigger finger. So I wanted to share this picture. Here, you see this? This over here. Okay. So shall I move on to the next question?
Yes, please.
Okay. Here. Now, no, it is appropriate action, okay, that we have to take here. A 63-year-old man has muscle aches and pains for several months. He's indoors most of the time. His blood tests reveal the following parameters that have been ongoing. Hemoglobin is, if you see, it's normal. And white blood count is also normal. Platelet is normal. Ferritin is low. Vitamin D should be this, and serum is 3.2, which is high. Calcium levels, appropriate next step. So what do you think the patient has right now? Can you diagnose the patient? So as the vitamin D is 21, okay. So the patient has vitamin D deficiency. All right. So let's see the answers in the chat box first. Okay. He has vitamin D deficiency. Okay. So he has vitamin D deficiency, and we will be giving them vitamin D followed by maintenance dose. Okay. So the most appropriate is to start a loading regime of vitamin D, typically for 7 weeks of high vitamin D, followed by lifelong vitamin D as maintenance, and repeat vitamin D is not necessary. No, mostly they do ask in the exam if we will be repeating a vitamin D or vitamin D has to be repeated. No, we won't be repeating a vitamin D. It's not necessary. And even at a normal value, maintenance dose is still recommended. Okay, there is no consensus on treating low ferritin with normal hemoglobin level. Okay. Shall I move on further?
Yes.
Okay. Yes, there's an increased calcium as well. So in case of vitamin D, there is increased calcium. So that is the reason there would be less absorption of vitamin D. All right. Now 24. A 24-year-old is out partying with his friends. Intoxication, he makes his way home, but ends up falling asleep with his arms across the back of the chair in his living room. The next morning on waking, he's unable to extend his wrist, and there is weakness of extension of his fingers. What is the single most likely structure that has been affected? Okay, we have answers over here. It's nice. Okay. Okay. Okay, yes, it's Saturday night palsy. Wait, lovely. You all nearly know the answer. Okay, let's move on to the explanation. So this is Saturday night palsy, occurs when radial nerve is compressed within the spiral groove of the humerus. Okay, it classically happens when intoxicated individuals fall asleep with their arm across the back of the chair. Okay. Yes, it's radial nerve palsy. Okay, let's move on to the next question. A 4-year-old girl seen with her mother at the urgent care in the hospital. She's having pain around her right eye. The pain started 2 days ago. She is febrile with a temperature of 38.5 degrees. There's no history of trauma. She's irritable. On examination, there's tender erythematous swelling around her right eye. An image can be seen. There is no image, I'm sorry. There is no gaze restriction or pain with eye movement. What is the single most likely diagnosis? Sorry, we don't have an image over here. I mean, couldn't even find one. But if you can make it out with this description, see, the eye is, there is pain in the eye. All right, there is pain around the eye and started 2 days ago, and there is also temperature. There's no history of trauma, but there's tender erythematous swelling around the eye. Okay, so this is what? Okay, periseptal cellulitis and orbital cellulitis. Yes, okay. So it is a periseptal cellulitis. This is a periorbital or periseptal cellulitis. Presents similar to the stem whereby there is an acute onset of swelling, redness, increase, warmth and tenderness of the eyelids. Fever is often a feature. Now, okay. Okay, shall I move to the next question? Okay, so any question? Okay. I'll try to give you the answer for why it is not orbital cellulitis in a while. I need to just see a clincher for that. Okay, now 26th question. A 34-year-old woman undergoes a total thyroidectomy for a toxoid multinodular goiter. On second day following the procedure, she complains of generalized lethargy, nausea, dizziness on mobilization. The patient is placed back into the bed and her brachial blood pressure checked manually. Following the inflation of the blood pressure cuff, the patient's hands begin to spasm. Okay, I think you can get the answer to this. Her wrist and metacarpophalangeal joints become rigid, flexed, with distal interphalangeal and proximal interphalangeal joints extended. What is the single most likely cause? Can you tell me? Okay, let's see the answers. Yes, it's hypocalcemia. So it is the carpopedal spasm that has been described in the question. See, sometimes the scenarios, again over here, the scenarios are going to be long, but if you know that the consequences of thyroidectomy and what you could have, so it will be easier for you to make a diagnosis over there. Again, you're saving up to about 40 seconds in that, okay? If it is the 6th pathognomonic of hypocalcemia, in this scenario, parathyroid glands have likely been inadvertently removed, which has led to a reduction of PTH. Okay, and subsequently there is hypocalcemia. Okay. Any question? Hypocalcemia, tetany. Yes, exactly. So, as in the question, they haven't mentioned that the parathyroid hormone was taken, the parathyroid gland was taken away. But as we all know, the location of parathyroid is just behind the thyroid gland. Again, sorry for my drawing over here. So when they do thyroidectomy, of course, these are going to be removed as well. Okay. So that is the reason why we had the spasms due to hypocalcemia. Okay. Next question. A 27-year-old man admitted to the psychiatric ward for an acute episode of psychosis. Okay. Over the past 12 hours, he has become increasingly agitated, confused, and pushes one of the nurses away from him. He has tried several times to leave the hospital. He has a history of prolonged QT interval diagnosed 3 years ago. Which is the single most appropriate medication to administer here? Now, okay, we have answers. Right. Why not haloperidol?
Because of the long QT interval.
Yeah, could be. Yes.
I think his medical history was not.
His medical history? I couldn't get you over there. Okay, fine. The answer is B. So I guess we both spoke on the same time. The answer is B, lorazepam. It is safest to give in the patient for rapid tranquilization. Haloperidol will worsen the QT interval, even if the QT interval was not mentioned. So you will be giving him lorazepam, okay? And haloperidol will worsen his prolonged QT interval. Clonidipine can also worsen his prolonged QT interval. It is also not drug used for rapid tranquilization. Okay?
Please, can I see the question again?
Yeah, sure. There you go.
Thank you.
Yes. Exactly. Yes, we do rule out Parkinsonism as well, but if I start telling you all that, it's going to be a more detailed answer. So, okay. Just let me know when I can move it.
Yes, you can.
Okay, thank you.
Thank you.
Welcome. Now, this question. Okay. Now, here we have to most appropriate next step in the management according to NICE. Now, the way I have trained myself, if I look into these, I know that somebody's talking about wheeze and asthma over here. Okay, so now a 32-year-old man continues to have difficulty controlling his asthma. He is wheezing with minimal exertion, and his symptoms appear worse at night. Okay. His current treatment regime is 2 puffs twice a day of inhaled beclomethasone and salmeterol as required. What is the single most appropriate next step in his management according to NICE? Okay. Do we have answers? Yes. Okay. B, inhale salmeterol. Okay, so the answer is yes, it's inhaled. D. Now this is inhaled, the answer is D, at oral montelukast, because they are asking you for the NICE guidelines. Okay, if in doubt in the PLAB exam, use NICE recommendation rather than BTS recommendations. When you go into the guidelines, you have both. But when it is not mentioned which guideline to follow, then you have yes, exactly. If BTS, then B. But when they say NICE guidelines, because the patient is as it
Miss,
is
could I see the question again?
Yeah, sure.
All right, thanks.
Okay. So if it is not, if they haven't mentioned NICE guidelines and they have mentioned BTS, then yes, B. If they have mentioned NICE guidelines, then you will be going on to with sorry, if they mentioned NICE guideline, then it will be montelukast. Okay.
Please, what if they don't mention any guideline?
If they don't mention any guideline, then it is the NICE guideline. Yes, exactly. If they don't mention NICE, but then you will be going with the NICE. See here. If in doubt in PLAB exam, use NICE recommendation rather than BTS. Okay. Okay. This happens.
Thank you.
This really happens. You're welcome. Now, now we have a rather long scenario. Again, we will go with appropriate management over here. All right. Now, a 48-year-old female a patient is under the palliative team for myeloma. He had been admitted to the hospice for symptomatic management. He feels nauseous and has been vomiting over the past few weeks. He's still able to be mobilized. He has a good appetite. He's on syringe drive ongoing, contains morphine sulfate and levonorgestrel. His wife is concerned that over the past few days, he has become drowsy, lethargic, agitated, and confused. His bloods are as follows. His hemoglobin is low. His white blood count is higher. It's within the normal, but at the higher side. His platelets are normal. His sodium is a little low. His potassium is fine. Calcium corrected is a little higher side. So if a patient has myeloma, his calcium is going to be on the higher side. Its PTH is, of course, low because the calcium is high. Then albumin is again low, and CRP is 22. Now, what is the single most appropriate management over here? What we will be giving the patient over here? You see, it is in the palliative care. Yes, if his patient is in the palliative care, here we don't do much to the patient. So yes, let's go to the answer. The answer is D. So patient with cancer-related hypercalcemia could be rehydrated with 1 to 3 liters of parenteral sodium chloride, 0.9% over 24 to 48 hours, followed by intravenous biphosphonates like zoledronic acid, and CRP's increase in cancer. So not a good indicator of infection. All right. So this here, they could trick you with a few things like maybe you would want to give them, some might choose amoxicillin or albumin infusions as well. But we need to have this in mind that the patient is under the care of palliative team in hospice. So because in palliative team, with the terminally ill patient, not just myeloma, any patient who will be mentioned with palliative team, you have to see that you're not going to do a much invasive treatment for that patient. All right, 30th. Okay, 39-year-old woman undergoes a cesarean section at 38 plus 2 weeks following a rupture of her membranes with the fetus in breech position. The procedure is uncomplicated and she is transferred to the postnatal ward. On day 2, post-cesarean section, midwife notes that her blood pressure is 165 over 106. She's alert and oriented, but she complains of bifrontal headache radiating to the back of her neck. A start dose of nifedipine is administered. Blood test reveals hemoglobin is low, platelet is low, albumin is high, bilirubin is high, evidence of schizocytes, and urine dipstick is 2+. Okay, what is the single most likely diagnosis over here?
Option A.
Okay, let's see what most of them have to say. Yes. So why do you think it's not preeclampsia?
Because you're elevated LFTs and there's also thrombocytopenia.
Sorry, she's admitted what?
Elevated LFTs and there's also thrombocytopenia.
All right.
And
yes.
the presence of schistocytes indicate that there's hemolysis going on as well.
Yes, yes. Yes. So yes, the answer over here is A, C, hemolysis, low HB, raised bilirubin and schistocytes, elevated liver enzymes, low platelet count. HELP syndrome may be associated with hypertension and protein. But if syndrome is present, choose HELP, not preeclampsia. Okay. So this 13, adult TS, 13 rules out TTP. All right. So we can take a 20-minute break over here.
Okay.
Okay. Okay. See you guys after the break. Thank you.
How long is the break for?
20 minutes. Okay. We will be seeing you guys back at 8:20. Okay, 8:24. Okay. Thank you. Hello.
Hello. Hello.
We'll wait a few minutes for other to join in, or shall we start?
Maybe wait till 3:30 or 8:30 by your time.
Okay. 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 Let's see. Fair enough.
Could you explain the orbital cellulitis question in the meantime, please?
Yes, with orbital cellulitis, there is pain while eye movement. Okay, Yashveen, right? You asked about it, and the eye with the orbital cellulitis, there is no painful eye movement. Okay.
In orbital cellulitis, we'll have orbital signs like proptosis, ptosis, and ophthalmoplegia, which means restriction of movements because of the pain, which is not present in preseptal or in periorbital cellulitis.
Yes, exactly. Yes, exactly. Okay, shall we start now? Because we'll try and wind it up quickly. It's nearly 8:35 here now.
So when are we going to start?
I am not ready to start here. And I asked if I should start so that we can wind up earlier as well.
I think we can start.
Okay, so let's start then. So
Hello.
okay, yes. So we have this question here on the screen. So we have to number needed for treatment. Find out the number needed for treatment. This is again an epidemiology question. Okay, let's start. So this is here number needed to treat. That is what we have to find here for the new drug to prevent type 2 diabetes mellitus. In a clinical trial was performed looking at a new drug called Zine. It is thought that this new drug is able to modify risk factors and reduce the risk of developing type 2 diabetes mellitus in pre-diabetics. 220 patients were randomized in two separate groups. One group received the new drug while the other group received the placebo. The participants were followed up for 15 years. The results is as below. So when we have this kind of a question, it's pretty much rare that we go for all this description given here. We normally just see this is what has to be needed. This is the entire thing that we have over here, the data we have, and then we have to find it out. Okay, so let's work this out. As I had already done with you guys, the absolute risk reduction. So over here, we have for this thing, number needed to be treated, we need to divide one with absolute risk reduction. And as we mentioned before as well, this is how we plot in. Okay. For the control group, to absolute risk reduction for control group, we use the C here and divide by C plus E, that is the total of this number. And for treated group, we divide A and the total number of cases over here. And we get, and then for the absolute risk reduction, we subtract the control group from the treated group. All right. Am I making sense till now? All right. Now next is the control group. Here is the answer to that. And the next is the treated group, ART. The answer is here. Okay. So now we have to find out the absolute risk reduction. And this is 0.2. So as the formula was 1 divided by absolute risk reduction, which is 0.2, the answer is going to be 5. That is B. Right? Is everybody sleeping today on this question now? Shall I move to the next question?
Yes.
Anybody wants to see the answer again? The question again? Okay, let's move on to the next question. Okay. Now, most likely diagnosis. All right. So a 31-year-old man sustained an injury in his left knee while playing squash. He describes placing his left foot down and then suddenly changing direction. Now, this is very important to note down, left foot down and suddenly changing direction. His knee then immediately began to swell and he had to stop playing. On examination, there is evidence of joint effusion in the left knee joint. There is also excessive anterior translation relative to the contralateral side when applying anterior force to the lower leg. The calves are soft and non-tender. So, can you people guess the answer? Come on, wake up, guys. Okay, I'll tell you the answers. And it is E, the anterior cruciate ligament, because he sustained injury, as I mentioned over here. Sorry, too quick. why he placed his left foot down and then suddenly changed direction. So the answer is here, anterior cruciate ligament tear. Injury with effusion and posterior anterior draw test is equal to anterior cruciate ligament tear. All right. The mechanism of injury is classic, placed foot on the ground, then twisted motion to change direction. Okay. Shall I move on to the next
Can I see the
question?
question again?
Yeah. Yes, sure. Here.
Please, could you explain when it's B?
Oh yeah, sure. See, in the question it is written, placing his foot down and then suddenly changing the direction. Okay, this is where you come upon with the diagnosis. His knee then immediately began to swell and he had to stop playing. On examination, there is evidence of joint effusion in the left knee joint. Okay, but when you see the calves are soft and non-tender, so Baker's cyst is not there, meniscal tear is not there. It is going to be injury to the anterior cruciate ligament tear. Okay. Effusion, injury with effusion and positive anterior draw test, anterior cruciate ligament tear. Okay. The mechanism of injury is classic, like when you put your foot onto the ground, then twist the motion to change direction. It is all of a sudden motion. In that, the anterior cruciate ligament tears off.
Okay, thanks.
Is it making sense? Anybody wants me to explain it more? Can you see this picture? I make it out. See, here is the anterior cruciate ligament. All right. So let's move to the next question. Now, again, an epidemiology question. In a study to detect the efficiency of new screening method to detect prostate cancer, a new imaging technique, Zetium scan was tested in 1,000 men. Okay, 200 of those who were scanned came back with features suggestive of malignancy. Upon further tissue biopsy, 190 of them were confirmed to be malignant. All right, what is the positive predictive value for the new screening method? Okay. Shall I share the answer?
Give us like a minute. Oh,
I can't hear you.
nothing. I was just saying like to give us a minute before revealing the answer. Yeah.
Oh, okay. Sorry. Okay. Actually, nobody's responding. So I'm like, maybe, I don't know what's going on.
Welcome.
Okay, let's share it. Now, this is positive predictive value. The answer is E, 95%. Now, this is true positive, the people who had the disease. Okay, that is false positive, the people who did not have the disease. Okay, and they were healthy. Now false negative and true negative. Basically, we are here taking the positive, the true and the false positive to find out the positive predictive value. All right. Okay. Shall I change the screen?
Yep.
Okay, thank you. Now, the other question. Now, this is the increased risk. Okay, 8-month-old baby is brought into the A&E following an episode of loss of consciousness and shaking. It started about 1 to 2 minutes, and there was a period he went stiff before losing consciousness. Okay, people get the idea what happened. He has been suffering from upper respiratory tract infections recently, and with the temperature over 38 degrees. His parents were reluctant to give him any paracetamol at home because they felt he was too young. So given the likely diagnosis, so the diagnosis is febrile seizures. Okay, so what is the risk of developing epilepsy in the future? So, any guesses?
10%.
Sorry?
10%.
0%.
5%.
5%. Okay. Yes. Okay. 5% is right. Even 2% is right. And some even say 10% is right. But mostly 2%.
Oh.
Even I have the answer of both of them, but mostly 2%. Actually, in PLAB exam, you will only be asked about simple febrile seizures. See, febrile seizures, there's a 2% risk of epilepsy in the future. It is 2%. All right. Note that the complex febrile seizures, which the risk of developing epilepsy in the future is much higher in complex. But in simple, and normally when they ask a question, it's about simple seizures. So the answer would be just 2%. So that is the reason when, with the key we had B, C, and D. That is 5% as well and 10% as well. But the most accurate answer, which I checked again, it was 2%.
Okay. I vaguely remember the PLAB it was given 2 to 5%. If I'm not wrong.
Yes, PLAB gave 2 to 5%, and but when I
Mhm.
went for PLAB 2, because we had this question as well, there they mostly told us 5% or 2%, not 10%. So I'm not really very sure. We have accepted option C and D too, since it was previously recognized that around 10% of all febrile seizures end up having epilepsy, but mostly it's 5 or 2%. Okay.
Yeah. Sure.
A 55-year-old woman had pain during intercourse. Now see, she's 55, so she is going to be postmenopausal. Pain during intercourse over the past 2 months. She feels burning sensation and soreness in her vagina. She also has increased urinary frequency and often complains of dysuria. On examination, there is erythema and atrophy of vaginal mucosa. So I think it's a very clear-cut answer, but you want to make guesses?
D.
D. That's topical steroid cream.
Oh no, estrogen cream.
Topical estrogen.
Yes. So this is a case of vaginal atrophy. Yes, vaginal atrophy due to menopause. So the answer is A. It is vaginal atrophy. Dryness is there. Soreness is there. Superficial dyspareunia is there in postmenopausal women. Topical estrogen. So these women also get recurrent UTIs, burning micturition. So you don't have to be prescribe prophylactic antibiotics over here, or give them cyclical hormone replacements. Okay, you will be giving them topical estrogen. Somewhere there are at times there you also have lubricants are also mentioned there, but if the estrogens is mentioned there, then you're going to choose estrogens. Okay. Now next question. A 27-year-old woman presents to her GP with an itchy rash on both her arms and wrist. It has been present for the past 2 weeks. She also complains of persistent soreness of the mouth, particularly after eating. Her past medical history includes asthma, and she smokes 5 cigarettes a day. On examination, there is a well-defined purple plague on the flexor surface of her wrist, but no vesicles are present. On inspection of the mouth, there are no visible ulceration, but lacy white patterns can be seen within the buccal mucosa. What is the single most diagnosis?
E. Lichen planus.
Okay. Yes. Shall I move on with the answer?
Yes, please.
This is lichen planus.
Simplex.
Yes. Lichen planus, because personally, my dermatology is very weak. So purple papules and wrinkle striae in the mouth. This is lichen planus. Treatment is with steroids. All right. Now, this is oral lichen planus and cutaneous lichen planus. They are going to be purple, pleuritic, purpura, and polygonal rash. And where is the sclerosing is, this is white thickened patches seen in the anogenital region in the women and the glans penis and foreskin in the men. So it is not going to be in the mouth. Okay.
Yes.
Okay.
Okay.
Okay. Let's move on to the second one. 37. Okay. Now here again, we have to make a diagnosis and we have the options here. Now, one thing what you could do is see the hemoglobin level here and the MCV here gives you a picture of microcytic, gives you a picture of microcytic here. So now this is an African 39-year-old African woman seen in the GP surgery for the tiredness of the past year. She has no weight loss and no previous history of medical illness. She has lived in UK her whole life. So there are some clinchers here. She's African, okay, African origin, and hemoglobin level. Then you have MCV. This you have. So, and then ferritin is within normal. So you can make up a little bit of a diagnosis here, right?
Yes. There are some stems contributing to the diagnosis. Yeah.
Stem is contraindicating to the diagnosis. That's what you said.
No, contributing to the diagnosis.
Contributing to the diagnosis. Okay,
Yeah.
thank you.
Yeah.
Okay. So it is now macrocytic anemia with normal ferritin, which is otherwise asymptomatic. No skull bossing, no splenomegaly. It's likely a thalassemia trend. So African origin is one of the pointer. And then the macrocytic picture, microcytic picture is another pointer, right?
How would you rule out fibroids like heavy menstrual bleeding?
There will be something given in the history, right?
Okay.
And if it is heavy menstrual bleeding,
history.
heavy menstrual bleeding, it could be because it's a chronic bleeding.
Mm-hmm.
So hemoglobin level wouldn't be that low.
And additionally, there should be something mentioned in the history as well, right?
Yes, additionally, there should be something
no previous
mentioned.
history.
Yes, yes.
Okay.
Okay. A 34-year-old woman presents to her general practitioner with facial reddening and spots. Okay. She finds that the redness gets worse after drinking alcohol or being out in the sun. On examination, there is generalized thickening of the skin with central redness. No blackheads or whiteheads are appreciated, but a small number of large pustules are present on her cheeks. Telangiectasia is also noted around the nose. She states the main issue is the redness on her face. Now, first of all, can you make a diagnosis?
Acne rosacea.
Yeah, right. It is acne rosacea. So what would be the treatment? Let's see the options. You want to see the options now? Okay, option is E. This is acne rosacea. So first line management is topical alpha-2 adrenergic agonist, that is brimonidine, and then it is a recurrent episode of facial flushing. It could be also mentioned that she has it while she goes out in the sun, goes, reoccurs when she goes into the sun, gets more intense while she goes into the sun. That could be one of the things mentioned in the paper as well. And it is more in the females compared to the males. Okay. Okay, let's move on to the next one. Okay. It's here asking about most appropriate action. Okay. 58-year-old man referred to the ER because of his high blood pressure, was repeated, measured 200 by 110. He has a history of hypertension and takes amlodipine. Fundoscopy was normal, and he remains asymptomatic. Blood tests, which includes urea, electrolytes, creatinine, glucose, all within normal limits. And ECG demonstrates sinus rhythm, and his GCS is 15. So what will be the next most appropriate step? Shall I move on with the answer?
Yes.
Yes. Okay. So we are going to give the patient oral ramipril and discharge, as he's already on amlodipine. Okay. So this is a case of malignant hypertension. Okay. So in malignant hypertension, so systolic is higher than 180 or diastolic higher than 120. 120 or higher. Conscious should be exercised in reducing the blood pressure to not to do it too rapidly. So as the patient is already on amlodipine, so ACE inhibitor is going to be added, ramipril, since he's already taken amlodipine. It is used, it can be used for malignant hypertension. So this is a case of malignant hypertension, of severe hypertension, because the systolic blood pressure is more than 180. Systolic was 200. Okay. And diastolic of 120 or higher. So diastolic was 110. Okay. And what would be the malignant hypertension? It would be severe hypertension. That is this description over here about diastolic, systolic, and diastolic. Then retinal hemorrhage or papilledema. Then it is going to be severe hypertension. All right. Okay, shall I move on to the next one?
Yes.
Thank you. Now, a 35-year-old man complains of worsening headache, palpitation, tremors over the past 8 months. He describes his symptoms as episodic, occurring up to 8 times a day with no apparent pattern. The last episode occurred when he went to the supermarket, where he came very sweaty and could feel his heart racing. The sensation subsided after 15 to 20 minutes. He denies any problem with his bowels or bladder, and his weight has remained stable. So his heart rate is 98 and his BP is 156 by 100. So what would be the diagnosis? There was a candidate who had done endocrinology when we were doing introduction. No guesses?
Pheochromocytoma?
Yeah, exactly. It's pheochromocytoma. And this is normally the way they ask during the exams. This is the scenario, classical scenario. It is pheochromocytoma, rare neuroendocrine tumor originating in the chromaffin cells, most commonly in the adrenal medulla, leading to large quantities of catecholamines. That is the reason that he doesn't have a set pattern. They come and go. Okay. The other thing is for the differentiation, hyperthyroidism does not lead to hypertension. Carcinoid tumor is associated with flushing, diarrhea, and right-sided heart failure. It doesn't have hypertension. All right. Can anybody tell me the test done for pheochromocytoma?
That's metanephrine.
Catecholamines, the level of catecholamines in the in the urine. Okay. Now next. 41. A 78-year-old man is admitted with a diagnosis of stroke with a left hemiplegia. He is bedbound on admission. He is expected to stay at the hospital for the next few weeks. What is the most appropriate measure to reduce the risk of venous thromboembolism? Can somebody tell me? I think those participants who were putting in the chat are not there anymore.
Pneumatic compressions, intermittent pneumatic compressions.
Yes, intermittent pneumatic compressions. Recognized guidelines recommend, see again here, these two options are very close to each other. And elastic compression stockings are done here in Pakistan. Normally that is what is done. But this is intermittent pneumatic compressions. This is the NICE guidelines and compression for venous thromboembolism prevention. Prophylaxis in acute stroke patient to be started within first 3 days of admission. Sorry. Okay. Let's move on to the next one. Now this. Okay, here, a 55-year-old man complains of increasing thirst and urination. He also has to get up in the middle of the night to urinate. His urine specific gravity is low and a random capillary glucose is normal. A fluid deprivation test is performed and the results is as follows. Now, urine osmolality is baseline is 40. After 8 hours deprivation is 640. And after administration of desmopressin is 610. First of all, can you can you make a diagnosis?
Diabetes insipidus.
Diabetes insipidus.
Diabetes insipidus, okay, and you have to differentiate it from?
It is nephrogenic.
Yes, exactly. That's good. So the candidates are not sleeping. That's good to know. Okay. So, so normal values. Okay. Sorry, serum osmolality is 278. Then after 8 hours of deprivation is 280. And after administration of desmopressin is 281. Okay, not much change over there. So what is going to be the diagnosis here? No guesses? All right. His urine becomes concentrated following an 8-hour fluid deprivation. This is primary polydipsia. All right. So this means he was drinking a lot of fluid. Am I making sense over here?
Just can I ask the question again?
No,
can you please go back to the question?
You want me to repeat the question?
Yep.
Okay, here you go.
Could you please also explain why is it primary polydipsia?
Okay. Just give me a minute. Okay. So in case of desmopressin, what does desmopressin do? Can somebody tell me? Just give me a minute.
Desmopressin is an analog to vasopressin, so
yes,
it
exactly.
should reabsorb more fluids from the renal tubules.
Yes. So it is not doing that, and your serum osmolality is also normal. Is not changing, right? Okay, so that is the reason it is primary polydipsia. It has nothing to do with diabetes insipidus, cranial diabetes, or nephrogenic diabetes.
So there's no significant change with the urine osmolality despite giving desmopressin. That's what you were saying, right?
Yeah.
Okay.
So before and after,
okay.
the values are almost going to be same,
Okay.
right?
Yeah. So that makes a point. Huh? Okay.
Okay. Yeah. Okay. Thank
And
you.
why is not nephrogenic diabetes insipidus?
Okay.
Okay. In nephrogenic, actually,
I think after giving this desmopressin, in
yes,
nephrogenic
go ahead.
diabetes, so the value would decrease.
Yes, exactly. The value would decrease because it is acting on the nephrons, so that the values would decrease. Okay.
Nephrogenic wouldn't respond to fluid deprivation or administration of nephrogenic.
Yes, exactly. Okay. Okay. Now next. Is a 33 Adrian is a 33-year-old man recently been diagnosed with HIV. Has been told by his GP to inform his wife about his diagnosis and practice safe sexual intercourse. His wife attends the practice a few weeks later, asking to change contraception from progesterone-only pill to a progesterone-only implant. Okay, she's not using any barrier method. In addition, she would also like to check her full blood count as she is previously anemic. It is clear that she's unaware of her partner's diagnosis. So what is the most appropriate action? What would you do? Continue to give confidentiality and do not inform Edwin's wife of his diagnosis, add HIV blood tests without Edwin's wife knowledge, break confidentiality and inform Edwin's wife about his diagnosis of HIV, refer her to the gum clinic, it's a gum clinic here, and inform social services infectious disease control. What are you going to do? If you're telling me something I cannot hear.
I think it's C, break confidentiality
and inform. Yes, exactly. It's going to be C. This is a serious communicable disease. If Edwin refuses to tell his wife, then the duty falls on the clinician to tell his wife. And this is something that you could even get it in your PLAB-2, hopefully. Okay. Now, next question. A 21-year-old man.
Sorry. Shouldn't it be informed through the patient notification?
Yes, when in that case, if there is a patient notification program, if they are asking you, and their husband says that when you try to consult the husband, that you have to tell your wife about it. It's a serious condition. So the husband is going to tell her that I don't. He's going to tell you that I don't want to. Then we are going to tell him that you don't really have to go and tell the wife. That is in PLAB-2. Okay, you don't really have to go and tell the wife. You would send letters to both of you, and you will be seen in the gum clinic, and there they are going to be tested, and then it is going to be told that way. But here, because that's not given in the scenario, and it is not Adrian's thing that you are talking about, so it's like it's not him we are talking about. So here, yes, you're going to break the confidentiality and tell the wife about it. Okay.
Okay.
Okay. Now, here is a 21-year-old man found by his housemate on the floor. It is evident that he had taken paracetamol overdose, as he is found to be surrounded by empty pill packs, and he has vomited. He was last seen by a housemate 6 hours ago. An ambulance is called and he is reviewed in A&E. An urgent paracetamol returns as 45 mg per liter and is plotted on the nomogram below charts. Okay, this is not given here. What is the most likely appropriate action? Now see, this is empty pill bottle, and he was seen by the housemate after 6 hours. We didn't have the chart, of course. So what are you going to see? Found by his housemate on the floor and return as 45 mg. So over here, we are going to see
Repeat, I think it's D, repeat the paracetamol levels if the chart is not given. And
No, the chart is given. It's below the
chart is given. It is plotted as 45. The paracetamol level is below the treatment line. I am totally forgetting the level of paracetamol for the treatment line. It is 75.
It's 150.
150. Yes, it is 150.
Yes.
Yes. And the level is done after 4 hours nearly. And it has already been 6 hours. So it is below the treatment line. So what are we going to do? What are we
Liaison with the psychiatry review.
We will opt for the psychiatry review because the acetylcysteine infusion is not necessary because it's already below the treatment line.
Exactly. So we'll liaise with the psychiatric review. See, the paracetamol level is below the treatment line, and therefore an acetylcysteine is not required. Okay. What are we going to do if the level is above 150?
N-acetylcysteine because
and it's infusion. We'll start the infusion.
Okay.
Yeah.
And if the patient presents within an hour with the staggered doses?
Staggered doses, we'll infuse him with N-acetylcysteine. But if he arrives within 1 hour, then activated charcoal.
Very good. Very nice. Who is this telling me the answers right now?
Ramin Mansoor.
Nice. See, your preparation is good. Okay. A 34-year-old, and for the rest of the people, please don't lose hope. Okay. Okay. A 34-year-old woman who is currently 8 weeks pregnant. Okay. Develops left iliac fossa pain. This is such the PLAB people really like all these kind of questions. She had undergone an in vitro fertilization for the recurrent pregnancy. She has had 3 spontaneous miscarriages in the past. She is a smoker. Okay, now her bloods, this is 82, so her hemoglobin is low, and white blood cell count is at the higher level, and CRP is raised again. So what is the single most likely diagnosis with an 8 weeks pregnancy?
Ectopic pregnancy.
Yes, it's an ectopic pregnancy. Should be at the top of the list since her HB is low and she could be bleeding internally. Okay. Sometimes there could be a scenario giving you a darker, like blackest discharge per vaginal, or or she has missed her periods. She's not so sure of her period, or she has a history of PID. So again, it's an ectopic pregnancy. Okay, shall we move further?
Yes.
Now, a 56-year-old man is present to the A&E with shortness of breath. He denies any cough or fever, but has noticed a significant reduction in his exercise tolerance over the past 3 months. On examination, there is reduced breath sounds in the right lower zone with dullness to percussion. There is also reduced tactile vocal firmness in the area. His trachea is in midline and the heart sounds are normal. So what could this be? Okay. See, even if you don't know anything, dullness to percussion means what?
Infusion. Water inside.
There is some resistance to the
Okay, and he says that he had tolerance in the past 3 months, reduction in exercise tolerance in the past 3 months, and there's percussion, dullness to percussion, and reduced tactile fremitus as well. So it is going to be what?
Effusion.
Yes, it's effusion. Okay, pleural effusion within the pleural leads to reduced breath sounds and reduced tactile vocal fremitus. Okay, now pneumothorax will, of course, there's air, so it is going to be increase in percussion note. All right, pneumonia leads to increased tactile vocal fremitus, not reduced, and is usually associated with cough. And here in the history, no cough or fever. Okay. And sarcoid commonly has no chest signs, but bilateral hilar lymphadenopathy is found incidentally on chest X-ray. All right.
Yeah. Please, when is the class ending?
I am targeting to do at least 90 questions, and this is the big mock August. So as soon as we are done with the 90 questions, I'll end the class. Okay. Okay. A 39-year-old man has been vomiting severely for the past few hours following an upper gastrointestinal endoscopy. He has developed chest radiation radiating between the scapula and the shortness of breath. The following day, he develops a fever, and his temperature is 39.1. Respiratory rate is 26. And heart rate is 110. On examination, he has subcutaneous emphysema on the chest and neck. So what could be the diagnosis?
Mediastinitis.
Okay. Anybody else?
Yeah, same, mediastinitis.
Okay.
Mediastinitis.
Yes. So it is an esophageal rupture. It's a complication of upper GI endoscopy, and subcutaneous emphysema can be seen, which suggests rupture of a hollow organ, that is esophagus aura. Okay, and this can lead to mediastinitis characterized by interscapular pain, fever, and shortness of breath. Okay.
Yeah.
Okay. Yeah.
Let's go on further. Okay, a 62-year-old man sustains a head injury following a fall. It was associated with loss of consciousness, and therefore a CT scan was requested. There's a small subdural hematoma with no midline shift, and his GCS is 15/15. Admission for observation is recommended. Following transfer to the ward, he starts becoming increasingly anxious and sweaty. He continues to pace up and down the ward, requesting that he goes out to shops. What is the single most appropriate management here? First of all, can you give me a diagnosis? What is
that? Delirium due to alcohol, withdrawn delirium minutes.
Yes.
Will develop.
Yes, great. Yes, it is because of alcohol deprivation. This is a very you could go with repeating a CT scan maybe, or lumbar puncture, but yes, this is because of deprivation. So here we are going to give him oral chlordiazepam peroxide because he is agitated. This is acute alcohol withdrawal. Okay. Should be CIWA score should be calculated to determine the amount of oral chlorperazine. This is not for your, and should be prescribed. Delirium tremors occurs 48 hours to 72 hours after acute cessation of alcohol and associated with confusion, hallucination, tremors. There is no indication for IV lorazepam. IV lorazepam is when he's getting agitated, screaming, shouting, something like that. All right. So there is no indication for IV lorazepam. There can be another scenario as well, in which they will find a person in dirty clothes roaming about in the park or something like that, and he seems to be a well-off person, but he's basically alcohol deprived. And over there also, this is the reason. I guess there is the option of IV thiamine to I think so. I'm not really that sure, but this is one another scenario for this.
Or when
Okay.
you please show the question again.
Yeah. I was telling you about alcohol withdrawal. So this is one of the scenarios where you're given the GCS with the history of Paul, you're given that he has a GCS of 15. But there could be another scenario that they found a person in dirty clothes roaming about in the park. And again, that is alcohol withdrawal. So alcohol withdrawal case. Okay.
But
Yes, thank you.
there is nothing to actually show that he's an alcoholic in this question. So how will you know it's alcohol withdrawal?
Yes, in this case, how will you know it's an alcohol withdrawal? That's what you want to say?
Yes, because there is nothing indicating that he's an alcoholic in the question.
Yes, it's not mentioned in the. Yes, I get your question. It is not mentioned in the scenario that he is he's on alcohol. But see, the GCS is 15, and the CT scan was requested, and it just showed a small subdural hematoma without any midline shift. So if this was the thing, he would complain if it was a hemorrhage or something like that. He would be complaining of increased pain in the back of his head, a severe pain kind of a complaint. With that, there could be some history of loss of consciousness, or the patient is a little drowsy, but this is none. There's nothing mentioned like that. The other thing that is noted here is increasingly anxious and sweaty. This is something. These are some of the things that you have in alcohol withdrawal.
Why can't we use rapid tranquilization in this question?
Because he's not agitated right now. He's not agitated. He's not shouting. He's not screaming. He doesn't have tremors, anything like that. So we will be not giving him IV lorazepam. Okay. Okay. A 94-year-old man has sustained a right femoral neck fracture from a road traffic accident. He was hit by a car going 50 miles per hour. He has been given intravenous morphine 10 mg as a bolus. He has become increasingly drowsy. His respiratory rate is 6 breaths per minute, heart rate is 50 breaths per minute, and blood pressure is 116/80. What is the single most appropriate management over here? Any guesses?
Naloxone, morphine overdose.
Yes, it's an overdose. Yes. Yes, you need to reverse the effect of morphine given naloxone. 10 mg is 10 mg for an elderly person is a little bit higher, too much. Okay, so you are going to reverse it. Okay.
Yes, can you show the question again?
Yeah, sure.
Thank you. All right, thank you.
Sure. Next, a 42-year-old man attends the urgent care center after stepping on a rusty nail while gardening. His last tetanus booster was 12 years ago. On examination of the wound, there is clean puncture site on the medial aspect of the left sole. The wound is cleaned and bandaged. What is the most appropriate management here? So are you going to give this person antibiotics and tetanus booster, or antibiotics, tetanus booster, and immunoglobulins, or just a tetanus booster and antibiotics only?
Tetanus booster only.
Tetanus booster only? Only the booster?
Booster and antibiotic.
Yes.
I
This
feel
was
it's
a
only
rusty nail.
oh.
Sorry?
Yeah, it's high risk.
It's high risk. It's a rusty nail. So we are going to give him a booster with antibiotics. Okay. All tetanus-prone wounds require antibiotics. Tetanus-prone, because the question states that it has stepped over rusty nail, or there could be a question soiled. So again, you're going to give him antibiotics. It also has been more than 10 years. If it was less than 10 years, so the booster wouldn't be necessary. Now you have to give him a booster as well. Okay.
Yeah.
Shall I move on to the next one? Okay. If you guys at any point want me to stop, I can stop. Otherwise, I'll go to 90 questions and then I'll stop. All right. Okay.
Okay.
This is a 65-year-old man with breathlessness and exertion and fatigue, which has worsened over the period of 1 year. Okay. So 65, worsening breathlessness over the period of 1 year. He denies having chest pain, palpitation, or wheeze. His medical history includes hypertension, which is managed with lerpenidipine. Now, this is amlodipine calcium channel blocker, I guess. He is a non-smoker. On examination, he has bilateral pitting edema to his ankles. There's no murmurs on auscultation of the chest, of the heart. His chest is clear with vesicular breath sounds on auscultation, and ECG demonstrates normal sinus rhythm. His blood pressure is 120/80. What is the single most appropriate next step?
Request anti-pro-BNP because it's associated with heart failure.
Because he is
Heart failure.
Yeah.
Because this patient is
yes, so the choice is going to be A, because see, he has simple symptoms of breathlessness. All right. Okay, and the other symptom is bilateral pitting edema of the ankle. So he is having breathlessness. Exactly. He has symptoms of heart failure, breathlessness, ankle edema. Start the investigation with BNP first. Okay, if this is higher, proceed with echocardiogram. All right. Now I just took this so that this was something where I was also, sometimes you are asked for these things, as said, like on the chest X-ray, you have to see pleural effusion. There are curvy lines, increased cardiothoracic ratio. So that's the reason I shared this. Now, these 2 points are there. Presentation, breathlessness, and ankle edema is there. And the third is the raised JVP. So that is not mentioned there, but we have 2 things. All right. Okay. Shall I move on to the next one? Okay. Now, a 67-year-old man is brought to the A&E with a central crushing chest pain. An ECG demonstrate ST's depression in leads 1, AVL, V5, and V6. What is the single most likely artery to be occluded? Now, leads 1, AVL, V5, and V6 represents which part of the heart?
That's the lateral wall, left circumflex.
Lateral wall.
So, which is the one that supplies?
Artery, left circumflex.
Great. Yes. So it is the lateral aspect, and C is the left circumflex artery. Exactly. So this is the ECG that is going to be there. I hope it's clear to you all. Can you see? 1, this is depression. Then AVL, there is depression. And then B5, B6, there is depression. This is the depression. Okay.
Yeah.
53 of a 14-year-old boy presents
Please,
to
can
the
I see the
ER.
question? Please, can I see the ECG again, please?
Yeah, sure.
Yeah, can see the question.
Just a minute, let her see the ECG. I'll go back to the question. Okay, now I'll just go back to the question. Okay, can I move on to the next one?
Yes.
Yeah. A 14-year-old boy presents to the ER, complains of severe head and neck stiffness, stiff neck, finds the room light very uncomfortable to his eyes, that is photophobia. He has high fever and has been feeling malaise for a few days. These symptoms began 2 days ago. On examination, he is oriented and cooperative. His heart rate is 100 beats per minute, blood pressure is 100/70, temperature is 39.5. He has reddish pin prick size lesions, that is rash, maculopapular rash on the lower back. He has recently traveled to Croatia. Which of the following is the best investigation to establish a definitive diagnosis? Shall I share the answer?
Lumbar puncture.
Yes.
Because he has meningitis.
Yes. Lumbar puncture is the most suitable as this patient likely has meningitis, which is the most commonly caused by Neisseria meningitis. A CT scan is required if there is evidence of raised ICP, as a CT scan would help rule out any masses or active bleed before doing a lumbar puncture. This is a recent travel history of Croatia. It is not this is a distractor. Okay, there is nothing like that mentioned anywhere. Croatia is a great place to travel and not many diseases that can present this way. Okay, let's move on to the second one. Next one. A 22-year-old man is brought into the A&E by ambulance following a car accident. He has lost large amount of blood and is disoriented and confused. IV fluids are administered and blood products are requested. His father arrives and says that he is Jehovah's witness and would refuse any form of blood products due to his religious beliefs. The patient is unable to confirm these details and becomes unconscious. There is no evidence of an advance directive. What is the single most appropriate next step? Come on, tell me.
Transfuse the blood. Because
Transfuse the blood.
Don't transfuse the blood.
No,
Don't
don't transfuse the blood. He's a
just give the IV
Jehovah's
fluids.
Witness.
But there's no advance directive.
Because it is
Only
emergency
the witness.
situation and the
He's a
patient does
Jehovah's
not
Witness,
present
right?
any form of consent that
We
we will do to.
Yes, here we will be doing transfusion because the patient does not have capacity. It is confused and unconscious. See, in UK setup, we have to have a mention of next of kin. So it is not necessary that if this guy who is 22 years old, he's an adult. So if he's an adult and there's no mention of next of kin and there is no advance directive by the patient, you can give him, you can transfuse, you can take decisions on behalf because there's nothing mentioned, no directive is mentioned, and he's 22. Okay, maybe his father doesn't want to have blood or blood products, but maybe he's not of the idea, or he doesn't believe in that. He wants to have blood transfusion. So this is here you will transfuse blood because the patient does not have capacity and there is no advanced directive. Okay, let's move on to the next one. A 56-year-old man with the background of squamous cell carcinoma of the lungs is seen at home by palliative team. He has had recent onset of bed breath, which he is very embarrassed about. His CT scan 2 weeks ago shows a large upper lobe cavity lesion. There is no obvious lesion seen in the oral cavity. His family is also concerned about his bed breath. What is the single most appropriate management? What will you give this patient? Pretty easy question.
Antiseptic mouth.
Antiseptic
Exactly.
mouthwash.
Antibiotics should be the answer. Yeah.
If there was an infection coming, see, I know it's a little thing. There's no antiviral, antifungal, but antibiotic is one that can be tried.
Can I answer the question again?
Yeah, sure. So it is going to be antiseptic mouthwash, but antibiotics is one that can be tried. They should be tried if there was any infection from the lungs. And since the infection is not, the antibiotic is not an option, so we will go with the antiseptic mouthwash. Best option. Okay.
Yes, because infection is in the lungs. So
yes.
So the answer should be antibiotic. But because there's no antibiotic
but
in
you
the
don't have an option here. Yes.
Yeah, so that's why next best would be antiseptic mouthwash.
Exactly. All right, next question. Oh, are you done? Shall I move?
Yes, please move.
Yes.
Okay. A 36-year-old man investigation for upper abdominal pain and is found to be H. pylori positive. Treated with appropriate eradication therapy. 4 weeks later, the patient is still complaining of epigastric pain. What is the single most appropriate test to determine H. pylori eradication? Sorry? Urea?
Urea 13 breath test.
Yes, urea 13 breath test. So retesting should be performed at least 4 weeks, ideally 8 weeks after treatment. The urea 13C breath test should be used to retesting as per guideline. Okay. All right. Okay. A 65-year-old man attends the emergency department with dizziness and a history of syncope early in the day. He has a pulse of 41 beats per minute. His blood pressure is 103 by 66, respiratory rate 23, and lead 2 has ECG shown below. Okay. Now, can you make the diagnosis? There's no medication given. Can you make a diagnosis? Oh, it's over there. It's a first-degree heart block. Okay.
Yeah.
Yeah, you can see the the distance here is more.
Okay. It is type 1 heart block.
Yeah.
Because
yes,
there's only prolongation of PR interval, but nothing else. It is type 1
but
heart
because
block.
there is syncope and dizziness, symptomatic heart block, so we will give atropine.
Exactly. Yes. Okay. Atropine is given intravenously. Next, 58. Now, a 62-year-old man.
Sorry, please, I did not see
Is
the
it? And
answer.
if please explain the ECG tracing, please.
Please, yes. I did not see the answer too.
You want me to explain this ECG or the other ECGs as well? Like, this is a first-degree heart block.
The one that was just done.
This is the first degree. Okay.
There is prolonged PR interval. That's why it's a first degree heart block.
Yes. See here, you see there is interval.
And it is constant.
And it is constant, yes. Pure interval increase and it's a constant block. So it's a first degree heart block.
Even if you leave the ECG, there is a pulse rate of 41. So the patient is
Yes.
already going in the bradycardia. So you will just
Bradycardia.
move with
So
atropine.
atropine. Sometimes, yes, sometimes people are not able to appreciate the ECGs. So it's fine, make use of the scenarios that you have over there. So it is helpful that way as well. Okay. A 62-year-old man complains of shortness of breath on exertion and ankle edema, ankle swelling. On examination, a soft pansystolic murmur can be heard at the left sternal edge. The murmur becomes louder when the patient is asked to breathe in. The jugular venous pressure is also noted to be elevated at 9 cm above the sternal angle. What is the single most likely vulvar lesion? Now, see, this patient has, okay, he's in heart failure. That is something there. So what is this pansystolic murmur that the patient has?
Regurgitation.
Mitral regurgitation.
Regurgitation, but it is a
Tricuspid.
It is a regurgitation. Okay, and which kind of?
Tricuspid regurgitation. Tricuspid regurgitation.
Tricuspid regurgitation.
Because mitral wall is at the apex.
Louder on inspiration, right? So it is a tricuspid regurgitation, and it is leading to raised JVP, peripheral edema, and shortness of breath. Pansystolic murmur can be heard on the left sternal edge, and the murmur is louder on inspiration due to increase in venous return. If we have time, I will give you a brief thing about other murmurs as well, but a little short of time right now. So, okay. Now, a 25-year-old diabetic man was found unconscious on the floor of the side of the road. He is known to be type 1 diabetic and takes insulin. He is profusely sweating on assessment with a heart rate of 110 and a capillary blood glucose level is 1.1. Okay, so normal is 4 to 11. What is the single most appropriate management here? If you even go from below, like if you see single most appropriate management and you see these things, you would know this is something to do with
glucagon. I am glucagon.
25 20%
gram.
glucose IV.
IV, yes.
C number.
See, this is a very interesting question again. If the IV is not, A is suitable when IV line is not yet put. Okay, but like in this case, the dose is wrong. It is how much? It is 9. And intermediate glucagon is 19. It is not 19. I think you give 50.
I think they meant to write 1 gram.
1 gram,
It's
yeah,
1
but
gram.
it is not given 1 gram. It is given 19. So the amount is here wrong. It is 1 gram. So intramuscular you won't give. You will give IV, that is 20% glucose intravenously. Here. Paramedics are able to secure an IV line, also administrate glucose IV. Okay. If an IV line is not mentioned, and if the doses is given 1 gram over there, then yes, glucagon. Okay. A 56-year-old, now what's single most likely causes of presentation here is refugee is found to have acute tuberculosis. Okay. Now he has started on quadruple therapy, including rifampicin, isoniazid, pyrazinamide, and ethambutol. 4 weeks later, he develops acute onset pain and swelling in his left big toe. So what would be the reason? Rifampicin, isoniazid,
Pyrazinamide. Uricemia.
Yes, it is pyrazinamide, which is going to cause hyperuremic, decreased renal uric acid clearance. This is a risk of. By the way, you should know the side effects of the rest of them as well. Okay.
Dr. Shahla, can we stop at question number 60 for today?
Is this Ramin?
No,
Yeah.
now let's continue to 70. To 70.
To 70.
Let's finish at 70.
Well, let's go with the majority, okay? I don't mind. I'll go with the majority.
I'm good with 90 questions. Please proceed.
90,
If anyone wants to
90.
leave, then one can leave, I mean.
No, 60.
90.
60.
90. Majority 90.
We have 30 more to go, then we should be hurrying up now. Actually, I wanted to share a lot more things, but as we are pressed with time, I would cover it up later. But okay, let's go for 61. That was Ramin who wanted to go to 60?
Yeah.
That's me as well. I guess you could take the recordings later on if you want to.
Yeah, I think I'll do that. Thank you so much.
Bye. Okay. 22-year-old women with a past medical history of severe eczema presents to her GP practice with weight gain. She has also noticed that she bruises easily and has a number of stretch marks on her abdomen. She has been on oral prednisolone for more than 12 months following an admission to the hospital for severe eczema exacerbation. What electrolyte abnormality can be expected?
Hypokalemia, because this is similar to Cushing syndrome.
It's a, yes, very good.
Cushing syndrome. Cushing syndrome.
Yes, exactly. It's a Cushing syndrome. It's induced Cushing syndrome because of steroid intake. So it is D. The patient is a prolonged history of oral steroid using indicates that this presentation is most likely Cushing syndrome, secondary to elevated exogenous glucocorticoids. Hypokalemia would be consistent here. People who go on long-term oral corticosteroids should have potassium supplements. Okay. Anybody wants to see the question or anything again? Shall I move on?
Move on, please. Move on.
Okay. Now, a 29-year-old pregnant woman presents to the early pregnancy unit with vaginal spotting. She denies any pain and states she's roughly 6 weeks pregnant from her last menstrual period. A transvaginal ultrasound demonstrated intrauterine pregnancy with a gestational sac measuring 17 mm. There is no visible heartbeat seen. Now, if you see this, she is 6 weeks pregnant. Okay, there is just a gestational sac. That means there's no heartbeat. So, what would you do in this scenario?
Repeat ultrasounds in the 7 to 10 days, because the gestation sac is 17 millimeter, otherwise it will increase in size. And this
yes. Yes. So by then the gestational sac would increase to 25 mm, and if it's a viable pregnancy, so we should repeat the scan after 5 to 10 days. Except it's a week, yeah. Later. Okay. The pregnancy of unknown viability, it has not met the criteria to confirm miscarriage. Okay. All right. And then beta HCG is no use when an intrauterine pregnancy has been confirmed. A repeat ultrasound scan should be performed at 7 to 10 days later. All right. Okay. Now here. A 30-year-old man presents to the optometrist for his eye checkup 6 months ago. He had an accident where he was struck in the right eye while playing tennis. He noticed a decrease in vision in the right eye, but thought it would go away. He denies any pain at present. On examination, the lens of the right eye appears cloudy and the red reflex is diminished. So what would be the likely diagnosis? He's just 30 years old. And he had injury while playing tennis.
It is acute open ankle glaucoma. Open ankle glaucoma.
Why open angle glaucoma? There is no pain. Denies any pain.
Retinal detachment.
There is no mention of curtains going up or down. He's
cataract.
Retinal detachment. Yes. Who said cataract?
Cataract.
Okay.
Yes,
Yeah,
cataract.
Yes.
It
is not retinal detachment. See, retinal detachment is sudden. Okay. And he could complain of curtain going up and down. It cannot be angle related, age related macular degeneration because he's just 30 years. It is cataract because of cloudy. right eye appears cloudy, and red reflex is diminished. So it is cataract. See, examination finding describes cataract. Traumatic cataract can occur secondary to blunt or penetrating ocular trauma. Retinal dischargement occurs after trauma in eye, causing flashes of light and numerous floaters, which may be preceded by a curtain coming over the vision. So it is not retinal detachment. If he would say these things right after the injury, then. But this is like for his eye 6 months ago, right? So it was like in the past. It was not sudden right now. Okay. Now, next question. A 59-year-old man presents with severe stabbing pain on the left hand side of his chin. Okay, the pain lasts only few seconds, but he described it as an agonizing electric shock type pain. He is able to point with a single finger where the pain occurs. The pain is brought on through touch, cold wind, and pressure around the area, particularly when he washes his face or shaves. So what is this?
Carbamazepine.
Yeah. Yes, carbamazepine. So it's carbamazepine. Trigeminal neuralgia treated with carbamazepine as per NICE guidelines. Okay. 65. A 44-year-old woman with severe learning disability.
Sorry, please, can we go back a little bit? Why not gabapentin and all those ones used for
Yes,
neuropathic
gabapentin is again you can give in trigeminal neuralgia or neuroleptic pains, but carbamazepine is the treatment of choice.
Is the what? You said carbamazepine is what?
It is
First line.
Treatment of choice. First line, treatment of choice. Carbamazepine is the treatment.
Okay.
You're
Thank
not
you.
wrong with gabapentin as well, but this is the second.
Okay.
Okay. A 44-year-old woman with severe learning disability is seen in the GP surgery for her annual medication review. She has a myrin coil in situ, which is inserted 6 years ago to manage her menorrhagia. She does not want the myrin coil to be removed because she feels that her menstrual bleeding is manageable. She is unable to weigh up the benefits of a marina coil removal or replacement. She lives with her sister. What is the single most appropriate action? Apply for a deprivation of liberty order, arrange a meeting to discuss a patient's best interest, apply to court protection, remove the myrin without consent, leave the myrin coil in situ. What would be the answer? These are the little tricky ones.
It's B, arrange a meeting to discuss the patient's best interest.
Yes, it's B.
No,
This is a complex case, requires discussion with other doctors, basically seniors and family members, to discuss what would be in the patient's best interest. In general, marina coil should be replaced every 5 years or removed after 5 years. Court of protection also makes decisions on welfare matters for people who cannot make decisions as at the time they need to be made. But involving court would be one of the last options when there are strong disagreements. So first of all, you're going to have seniors, doctors, senior doctors and family members to discuss the case about the patient. If that is not done, then you could ask for the court protection. That is as the last resort.
Please, can we go back to the patient? I think we are too fast.
You want to be here? Question?
Yeah.
Okay. You're speaking a little softly. Can you speak a little louder, because I can't make it.
Hello, you just said that marina needs to be changed after how many years? I wasn't
5
sure
years.
about that. Every
Taken
5
away
years is
or replaced after 5 years.
okay. Okay, thank you.
Okay. Thank you. Thank you.
You're welcome. Now, 66. A 27-year-old man underwent laparoscopic appendectomy for acute appendicitis 2 days ago. On review during the ward round, he's well with no fever, no nausea, vomiting, or significant abdominal pain. However, he is noted to have mild scleral icterus. Okay, so this is hemoglobin. His hemoglobin is normal. Bilirubin, total bilirubin is raised. Direct is, I guess it's normal. Then rest of his investigations are normal. So what would be the answer here?
Gilbert syndrome, only bilirubin, total bilirubin is rest.
Yes.
Gilbert.
Yes, exactly. It's a very direct case. Gilbert syndrome is an autosomal condition associated with a buildup of bilirubin due to defective conjugation enzyme in the liver, usually during periods of stress, such as surgery. There is isolated rise in unconjugated indirect bilirubin with no other liver function abnormalities. Treatment is supportive. Okay. Next. A 38-year-old man presents with intermittent upper abdominal pain with loose, foul-smelling stools. His symptoms have been ongoing for the last 8 months. He denies any blood in his stool. His blood test results show evidence of iron deficiency anemia. Which test would confirm the most likely diagnosis? See, he is just 38 years old. So what would be the diagnosis?
Celiac disease.
Yeah.
And anti-tissue transglutaminase antibodies will be done.
Yes. Why? Endoscopy and biopsy? No. Yes, we would first initially, one possibility here, there could be celiac disease. Endoscopy and biopsy would confirm this. Anti-TTG antibodies do not confirm the diagnosis, but it is a good investigation to start with. So endoscopy, yes, endoscopy and biopsy is the diagnosis, to confirm the diagnosis. Okay. If it is positive, they would still need to go for a biopsy. The question is asking specifically about what would confirm the diagnosis. So anti-TTG would not confirm the diagnosis. Only endoscopy and biopsy is going to confirm it. This is something PLAB plays on, confirming the diagnosis or diagnosis, the gold standard, and just to have the thing, have a test. So yes, this is a part of it, but this is going to confirm the diagnosis, endoscopy and biopsy. Okay.
Okay.
Shall I move on to the next one?
Yes.
Okay, sorry. A 52-year-old man presents to A&E with an acutely painful swelling on the base of his right toe. Okay, the swelling started about 2 days ago and he denies any trauma. So you're getting to the point, what they're trying to tell. His past medical history includes gout, for which he takes allopurinol. His last flare of gout was 18 months ago. On examination, he's apyrexic, but clearly in pain. A diagnosis of acute gout is suggested. He's prescribed naproxen. What is the single most appropriate next step? Now, when he has gout, okay, so are you going to stop the allopurinol because of the flare-up, or refer to a rheumatology, check serum uric acid level immediately or after 4 weeks, or change allopurinol to fiboxetate? What would you do? Okay, let's see what you would not do. Would you send this person to a rheumatologist?
No, because we will treat it in acute phase.
No,
So
because
you wouldn't send him to the, and will you check his uric acid levels immediately?
No.
Will you change his aripiprazole to febuxostat?
No.
No. I think I will.
Okay, so
Stop allopurinol during acute flare of gout.
No.
no, you wouldn't stop
Yes.
his. You would not do this either. Basically, you are going to check his levels of uric acid after 4 weeks, not right now. You are going to give him, continue him with allopurinol, should not be stopped during an acute flare of gout. Once resolved, follow up the person after 4 to 6 weeks and check serum uric acid level. I can't hear you. Can you be a little louder, doctor? I cannot get anything what everybody's talking about over there. So the question here was, are we going to stop aripiprazole? We will not be stopping aripiprazole. We will not be referring to rheumatologists, but we will be checking the uric acid levels, serum uric acid levels after 4 weeks. Okay. Shall I move further?
Yes.
Now, 69. A 54-year-old man attends his GP due to difficulty swallowing. This started 3 weeks ago, and he's 54 years old. He's initially only with solids food, but progressed to difficulty with thick liquids. He has a past medical history of chronic gastroesophageal reflux disease. So what is the most appropriate investigation over here? What we are going to do?
Endoscopy.
Okay. Yes, we are going to do an endoscopy. This gentleman presents with symptoms of progressive dysphagia on the background of GERD. Cancer should be suspected and an urgent endoscopy arranged. Okay. Can we move on to the next one? Okay, a 44-year-old woman complains of double vision when reading the newspaper. It has been slowly getting worse over the past 3 days. She denies any pain or blurring of her vision. The double vision appears when looking to the right. Now see, the double vision appears when she's looking to the right, improves on looking to the left. On examination, there's evidence of stauropia in the right eye with failure of abduction. What is the single most likely involvement?
Left
Right
trochlear
abducens.
nerve.
Right abducens.
Right abducens.
Yes. This is a right rectus palsy due to damage to the right abducens nerve. Due to the subacute nature, demyelination disease should be considered. Okay.
Excuse me.
Yeah.
In the question, it's mentioned that when she looks down, she has complaints of double vision. Like when she's reading a newspaper, she must be like moving it up and down.
Yeah.
How do we clear it up if it's abducent or it's trochlear?
Okay, you want that. Okay. There's a diagram. Okay, just a minute. Give me a minute, okay? Give me a minute. I'll share with you right in a minute. Okay, sorry, I was not able to share the screen. Just give me a second. Okay, so you were asking me that how would we differentiate between the right abducent and the trochlear? Hello?
Yes. Yeah.
Okay. So what is basically the function of trochlear? It is it in a way is the superior oblique, right?
Yes.
Okay. So what does the trochlear nerve does? Diplopia on if it is affected. So there is going to be diplopia. So do we have diplopia over here? Blurring double vision is here when looking to the right. So the right part is controlled by the right side of the right abducent nerve.
Okay.
Okay, it controls the lateral rectus.
Yeah, it is controlled by lateral rectus. Yeah.
Yeah. Okay. So the abducent nerve, if we look to the left and see double, then the lesion is on the left. If we look at the right and the lesion is on the right, then it is the right.
Yeah, right abducent.
Am I making sense here?
Yeah, kind of.
Yeah, kind of. Okay. Okay. Right. Okay.
Sorry, but if it was a trochlear nerve injury, what would happen then? Would the patient not be able to see?
There will be diplopia
now,
on looking
the
down.
trochlear nerve injury is going to trochlear nerve injury is going to give you again diplopia, but it is going to give you diplopia on downward gaze.
Trochlear is mainly vertical diplopia and abducent is horizontal diplopia.
Yeah.
Horizontal diplopia, exactly.
And the difference is both innervate the opposite ones, like abducents on the same side and trochlears on the opposite side.
Opposite side.
Yeah.
Yeah. Thank you.
Welcome. It's a little confusing for me as well. Okay. Now the next question. This is a little lengthy. Okay. Now here. Is this the question is visible to everybody? Totally visible? I hope nothing is missing. Okay. A 55-year-old woman is brought to the emergency department by ambulance. During the night, she was awake by severe abdominal pain with nausea and vomiting. She has rectal bleeding and diarrhea. On examination, she looks to be in severe pain. She is in severe pain. Okay, sorry. She looks to be in severe pain and is peripheral shutdown. She is known to have atrial fibrillation. Her abdomen is soft, very tender, but there is no guarding or rebound tenderness. The bowel sounds are absent. Okay, so her heart rate is 128. Blood pressure is 110/70, saturation 98, temperature is 37, so she's afebrile. Respiratory rate is higher. Now the ABGs. See, her pH is low, so it is acidic.
Acidosis.
Okay, acidosis. So which acidosis now? Lactate level is also high. Okay, so this patient is having what? Something if you get, okay, now everybody has made up a diagnosis in their minds or not?
Yes, it is mesenteric ischemia.
Let's keep it simple. Okay, let's keep it simple. Let's start with okay, it is mesenteric ischemia. Okay, if we say, so how do if we don't want to go around with this, but the ABGs, because some of the here candidates might be a little confused with the ABGs. Here you have decreased bowel sounds. Where did it go? Bowel sounds are absent.
Bowel sounds are absent.
No guarding and no rebound tenderness. So we come to these two. Okay.
Yeah.
Small bowel obstruction, mesenteric ischemia. All right.
Yeah.
Okay. But again, there is rectal bleeding and diarrhea. So here.
It can't be
In small bowel
obstruction
obstruction, there is not going to be any rectal bleeding or
or
diarrhea.
diarrhea. Yeah.
Yes.
Another thing, it is associated with atrial fibrillation.
Yes, exactly. It is related with atrial fibrillation. So yes, exactly. I didn't want to say that atrial fibrillation because again, there are certain people who would be a little thing with this. So if you just try to find out the simplest thing over here, because yes, small bowel obstruction again is going to have absent bowel sounds, no guarding, no rebound tenderness, but there will be no rectal bleeding and diarrhea, which is going to be there in mesenteric. Again, if you are able to do these ABGs, now there is acidosis. Now, bicarb is within normal, okay? And then you have carbon dioxide, again, it is a little low. So here you're not getting it, but here in the lactic acid, lactate is increased. Again, so we have a small bowel, a mesenteric ischemia. Okay. Fine, shall I change the slide? And yes, sorry, I forgot to mention atrial fibrillation. With atrial fibrillation, there are chances of getting what you call plagues, or what you call them, ambulance. So because of that, there is a chances of ischemia or a small bowel ischemia, right? Okay. Now, a 67-year-old man presents to the general practitioner with worsening memory problems. He's 67, worsening memory problems in the past 2 to 3 years, with deteriorating mobility. On questioning, he admitted a number of episodes of wetting himself and being unsure of how this happened. A CT scan of the head is requested. What is the likely finding of the CT scan? Ventriculomegaly.
It will be E, frontotemporal lobar degeneration.
Is a frontal lobar degeneration. With frontal lobar degeneration, would you have bedwetting? Would you
I
have
was expecting to see normal pressure hydrocephalus.
This is ventriculomegaly, which is, this is normal pressure, dementia, urinary incontinence, and gait abnormalities are there.
Yeah.
And the CT scan reveals, I guess there would be a CT scan there, but this is normal pressure hydrocephalus. Okay.
Can you go back to the question, please?
Yes.
Thank you. Okay.
Okay.
Yeah.
Okay. Now, a 40-year-old farmer presents to the GP after noticing a change in his fingernails, which has been persistent over a few months. He takes regular cyclosporin for treatment of refractory arterial vasculitis. On examination, you note mild paranoia and damage to the cuticles, as well as dirty yellow-green pigmentation of the nails. A picture can be, we don't have a picture. What is the most likely diagnosis? Now, you have to make a picture. It says that cyclosporin, he's on treatment for refractory vasculitis, and on exam mild paranoia and damage to the cuticles are there. Okay, so we don't have a picture here. If we had a picture, it would have been a little easier, but we don't get pictures. see what the answer is. It is onychomycosis, as known as Tinea eugenias, a fungal infection of the nail. Now, see, the patient has been history of cyclosporin use for relevance, because patient who is immunosuppressant are more likely to develop onychomycosis. This is the fungus of the nails.
Can you show the question again, please?
Yeah, sure. I'm trying to find a picture of that. Okay. Okay.
Yes.
A 3-year-old boy is brought to the general practitioner with worsening fatigue. He does not appear to be energetic as the other children in his paper. He's also had a number of upper respiratory tract infections this year, which is not normal for him. On examination, the child is pale, lethargic, palpable hepatosplenomegaly. Blood test reveals hemoglobin is low. Okay, white blood cell count is again low. Platelets are low. There are lymphoblast cells that have condensed chromatins, minimal cytoplasm, and do not contain granules. What is the single most likely diagnosis?
Acute
Acute
lymphoblastic
lymphoblastic
leukemia.
leukemia. It's B.
Again.
Acute
Acute lymphoblastic.
lymphoblastic leukemia.
Yes.
It's B.
Yes, it's B. See, it's acute lymphoblastic leukemia, which is common in childhood. So if it's a child, it's an acute lymphoblastic leukemia affecting children between age 2 and 4 years old. Patient usually have a pancytopenic and blasts are noted on film. The presence of oral rods and more than 40 years old suggests AMLA, not ALLA. Okay. If we had if it was a case where there was age was more like 40 years or older age, then we would have gone for AMLA, right? No? Yeah. Tell me.
Yes.
I'm trying to find this as well. Okay. If it is ALL, acute lymphocytic leukemia, so it is going to be a child. If it is an acute myeloblastic leukemia, it is going to be acute myeloid leukemia. It's going to be an adult. So this is going to be, they're going to be either increased or decreased neutrophils of neutrophils, blast cells are seen. And there is going to be bone pain, anemia, infection, bleeding. All this are going to be present, but this is going to be in adult onset. Okay.
Yep.
Am I making myself clear or are we lost?
Yes, it's clear.
Clear? Okay. Okay, let's move on to the next one. 75 or 30. I would take a break at 80, okay? Just for about 10 minutes. Is it okay?
That's okay.
Yes.
Okay. Okay. A 35-year-old woman attends emergency department after an episode of chest pain. Okay, this is 37 with a chest pain. Described as central crushing chest pain that comes on breast and radiate to the left jaw. She's associated with clamminess and lasts for 2 minutes before resolving. In department, she has another episode. An ECG is recorded which shows ST elevation in leads 1, 2, 3, and 4. GTN spray completely resolves her pain. She has a normal ECG when no pain is present. She has had multiple episodes of this in the past 6 months, lasting about 5 to 20 minutes. It usually occurs while she is in bed trying to sleep. She smokes 5 cigarettes a day and has no other past medical history. Serial troponins are normal. What is this?
Costochondritis?
It's
Is
aortic
it
aneurysm.
atrial myxoma?
It's C.
Why it would be costochondritis?
Disciplinary
It's
versus present.
A.
I can't
A.
hear.
A.
Yes. Yes, it is A. It is A. See, the patient presents with cardiac sounding chest pain. See, there is elevation as well. Whoever was saying costochondritis can't be costochondritis because there's going to be no ECG changes. Okay, so there was ST segment elevation, which is transient. Such a history is typical of variant or prismatic angina. Prismatic angina. Okay, when the patient is pain-free, there'll be no change in the ECG. And okay, fine. The serial troponin will be normal. Okay. I'm moving on to the next one. A 33-year-old man presents with mild headache, myalgia for 2 days, followed by a high fever, chills, rigors, and a cough. This cough was initially dry but progressed to be productive. He has returned from a conference in Aegean Islands. His temperature is now 38.1. On examination, he is dysphonic, and his sodium is 131. And chest X-ray shows patchy alveolar filtrates. Now, what is the single most causative organism? Even if you don't have the entire history of sodium and X-ray chest, there's something that really points out.
Because Iceland. He visited to recent trip which contain Iceland water.
Yes, yes, yes. So it is Legionella pneumoniae, and although there are all these findings, see, Legionella travel, respiratory symptoms, and hyponatremia. This is something that Legionella has it. And then there is decreased lymphocytes as well over there. Then the treatment is macrolides or tetracycline. Okay.
Could you please go to 75th question answer?
Can I take the do it when I go for break?
I just want to see the answer. Like, is it coronary?
72?
Yeah, 75, yeah. Okay, coronary artery.
Yes, this is it.
Okay, thank you.
Shall I change?
Yep. Thank you so much.
Okay. A 17-year-old girl with progressive left knee pain over the period of 6 months. She fell on her left knee 6 months ago after twisting injury when playing football. On examination, mercury test is positive on the left knee. What is the single most diagnosis?
Meniscal.
This is meniscal tear.
It's the meniscal tear.
Yeah. A positive mercury test is indicative of meniscal tear. Okay. 78. A 30-year-old man presents to the urgent care center after coughing up blood. Due to his smoking habit, he usually has cough, but it has been considerably worse over the past 2 weeks. This symptom started soon after he completed course of antibiotics for upper respiratory tract infection. He denies having any fever, night sweats, or weight loss. On examination, his blood pressure is 148, 192, auscultation, chest, bilateral crackles, and pedal edema to the mid-calf. A urine dipstick shines 3+ protein and 4+ bloods. Bilateral pulmonary infiltrations are seen throughout the lung field. On chest X-ray and pulmonary function test identifies an increased carbon monoxide diffusion capacity. What is the most likely cause? Can you tell me?
I think it's Goodpasture syndrome.
Yes, it is Goodpasture syndrome. So what is Goodpasture syndrome? It is an antiglomerular membrane, a rare vasculitis causing autoantibodies against the glomerular basement membrane and alveolar basement membrane. It is considered a type 2 hypersensitivity reaction, typically in patient 30 years old who smokes. Okay. It is more common in men and has a bimodal age distribution, that is, it peaks at 20 to 30 and at 60 to 70, and it has pulmonary hemorrhage. And smoking is one of the reasons. Okay. So there is a triad: rapid progressive glomerulonephritis, pulmonary hemorrhage, autoantibodies to glomerular basement membrane, and alveolar basement membrane. Shall I move the slide?
Yes.
79. A 44-year-old. Somebody saying something? Okay. A 44-year-old woman attends emergency department with a painful right groin that started a day ago. She has vomited twice in the morning and feels abdominal bloating. She has not been able to open her bowels for the past 48 hours. On examination, there's abdominal distension.
Because when I come back, I want to sleep. That means when I come back, I'll go to my house.
Irreducible mass below the inguinal.
No, I want to.
What is?
Cold.
Can you please mute yourself? Rest of the people are getting disturbed here. Okay. Now this is referral to the general surgeon indicating a surgical emergency, referral to the gynecology indicating a gynecological emergency. So what is this basically?
Femoral hernia. I think this
We are going to, this is a femoral hernia, and as it is below the inguinal ligament, and she's going to be referred to the surgical ward.
Okay.
Okay. Now the next 80. A 46-year-old man presents to the GP with swelling of the wrist. He denies any pain or limitation in wrist movement. On examination, there is a smooth 10 by 10 firm swelling on the lateral aspect of the flexure tendon of the right wrist. It is not tender. So what it is? Baker's cyst, nodal arthritis, Morton's neuroma, ganglionic cyst.
Ganglion.
Ganglionic cyst.
Exactly. It's a ganglionic cyst, and it is a conservative management, as it is not causing pain or pressure in the local area. And Baker's cyst is found behind the knee, and Morton's neuroma is found on the foot. Okay. Okay. I'll just take a 10 minutes break. Okay. And I'll just see you in 10 minutes. Okay.
Yeah, sure.
Yeah, sure.
Shall we start? Somebody wants me to get back to 75 question.
Yes, please.
75?
Yes, please.
Yusuf? All right.
I think we were done till 80, I guess.
Yeah, we were done till 80. I'm just taking 10 more. And the rest we will be doing in the paid sessions. Okay, let me know when I can move the screen. Shall I move the screen?
Thank you.
Welcome. Okay, now 81. All right. Now, this is a 71-year-old woman attends the nephro clinic for follow-up for the stage 4 chronic kidney disease. She is currently struggling with fatigue, general aches, spasms, and bone pain in her hips, lower back, and shins. Now, her blood hemoglobin is low. eGFR again is low, and corrected calcium is low. Vitamin D, of course, is going to be low. Phosphate is 1.9, which is high. What is the most likely diagnosis over here?
I think it's secondary hyperparathyroidism.
Yes, it's secondary hyperparathyroidism. So the diagnosis here is secondary hyperparathyroidism as a result of the chronic kidney disease. So patients with chronic kidney disease have a decreased production of 125 hydroxycholecalciferol, and by the kidney, which leads to decreased absorption of calcium from the intestine. Then tertiary and primary hyperparathyroidism would have a raised calcium levels. So, okay, and CKD has also the result can also result in anemia. Here. Okay.
Please, can I read the explanation again?
Yeah, it's a secondary hyperparathyroidism. Okay, it's a result of chronic kidney disease. So when you have a chronic kidney disease, your vitamin D levels are going to be low. Because it is converted, vitamin D3 is converted in the kidneys. And even the calcium is decreased. Okay,
Please, can you explain the tertiary hyperparathyroidism?
Hyperparathyroidism?
Tertiary.
So what is what is the function of parathyroid? Do you know the function of parathyroidism?
The
parathyroid hormone
in the blood through absorption of calcium from bones.
So see, parathyroid hormone function is basically the maintenance of calcium level in the body. Okay, so if it is if it is going to calcium level in the body, right? So if it is hyperparathyroidism, so what is going to be the what is going to be the what is going to happen then? So PTH is going to be high. Okay. So there is going to be calcium is going to be high, but here the calcium is low because vitamin D is not there because of the chronic kidney disease. And it is secondary. In primary, the calcium level is going to be high, but in secondary, the calcium level is going to be low. I'm sorry, I'm just having a chill because of the chronic kidney disease. Okay.
Yeah, and tertiary hyperparathyroidism is also because of excessive secretion of PTH after long-standing secondary hyperparathyroidism. But the situation is that we have hypercalcemia in the tertiary parathyroidism.
Yes. Hypercalcemia and parathyroidism. Yes. All right. Let's go on to the next question. A 35-year-old man with rheumatoid arthritis is considered further treatment option. A decision is made to start infliximab. Which is the mechanism of action of infliximab? Do you know? Anybody knows the mechanism of action? It is a tumor necrosing inhibitor, factor inhibitor. Infliximab. Okay. '83. A 61-year-old woman presents with vague abdominal pain. She's concerned that in the past 6 months, she has lost 10 kg of weight without trying. She complains of feeling fatigue, but otherwise well. She smokes average 10 cigarettes a day for the past 20 days. On examination, she appears pale and has conjunctival pallor. A palpable enlarged lymph nodes is noted in the left supraclavicular region. So, and she's anemic as well. So what is the single most appropriate action?
Ultrasound.
It's B.
It's B.
Gastroduodenoscopy.
Endoscopy.
Yes, exactly. There is several indicators of the case which suggest an underlying primary gastric cancer. She has a palpable left supraclavicular nodule, which is called Virchow's node. Anemia is a feature of gastric cancer. Many may think this is colorectal cancer and do a colonoscopy, but the Virchow's nodules are feature pointing towards gastric cancer rather than colorectal cancer. The point of the DD here is this. Virchow's nodules. Enlarged node. All right. Okay. Next question. A 28-year-old man presents with worsening leg weakness. 2 days ago, he noticed numbness in his feet, which has progressed to weakness involving his lower legs. Now, feet to lower legs, okay? He is worked because he's now struggling to walk due to leg weakness. The week before the symptoms started, he has an episode of diarrhea after attending a family barbecue. Other members of his family experienced diarrhea, but nobody else has symptoms of weakness. On examination, the power in his lower limbs is 1/5 bilaterally and 4.5 in distal upper arms, and absent reflexes in the ankles and the knees bilaterally. A decision is made to admit to the ward. Single most important parameter to monitor, which may indicate impending respiratory failure. What are you going to monitor?
Respiratory rate.
Respiratory rate.
You are not, yeah, it is related. You are going to see the force vital capacity. Like after this is a Gullian system. So you are going to see the force expiratory capacity of the patient, force vital capacity of the patient, like baseline and 4-hourly is important to monitor for impending respiratory failure, because if it goes further on, then the patient can have respiratory failure and would have to be intubated and put on a respirator, on a ventilator. So FVC has to be monitored every 4-hourly for this patient. And is it clear?
No, it's not.
Sorry?
Yeah, it is clear. We can move forward, I guess.
Okay. So a 61-year-old woman has been having a sore leg, left leg over the past 2 days. Her left shin is painful, swollen, and tender to touch. She has a temperature of 38.2 and a heart rate of 91 beats per minute. She's a smoker. Okay. Now you have 2 pointers here now. She has a known history of peripheral artery disease, okay, hypertension and diabetes. She's a regular medication include ramipril, metformin, atorvastatin. Her medical history include anaphylaxis when she took penicillin in her teenage years. What is the single most appropriate advice? What would you do?
Withhold atorvastatin.
Atorvastatin
Yes.
cause erythromycin and atorvastatin had reaction.
Yes. She has cellulitis and atorvastatin has to be held with the first line, but since she is penicillin allergic, clarithromycin is a suitable alternative. She needs to stop atorvastatin while taking clarithromycin, as can alter the metabolism of statins, leading to an increase in plasma levels and therefore increasing the risk of myopathy and rhabdomyolysis. Okay.
Please, the question, please, let me see the question again, please.
Yeah, sure. Here.
Thanks, thanks.
Okay, welcome. Now, 86. A 3-year-old child is brought to the A&E with arm pain. It started after his father pulled him up over a fence with his left arm. Because the child is now not using his arm and becomes very distressed if any attempt is made to move his elbow. On examination, the arm is being held in extension and the forearm is prone. There is no swelling, deformity, or bruising. What is the most likely diagnosis? He's 3 years old.
A green stick in fracture.
A green stick fracture is usually a twisted one. It is green stick. Stick. What do you call? Fracture is usually in children who have had a twisted, who has had a twist of the arm, like in a forceful twist. Okay. So it is not a green stick fracture, but yes, if you see the age of the child over here, it's 3 years. You could think that, but it's just the pulling. Okay. It is B. Pulled elbow occurs when a child is usually less than 4 years and is abruptly lifted by their wrist or arm. The child has been lifted by the wrist with his left arm. Okay, so pulled up. So this leads to a slippage of the annular ligament of the head of the radius, leading to partial dislocation. Treatment is just reduction, which leads to instant resolution. Green stick fracture, if they are asking you if they want to ask you green stick fracture, they are going to mention a forceful or a force push, something like that in the question. Okay. Let's move on to the next one. 87. A 75-year-old man presents with a 6-month history of leg pain on walking. He describes this as a cramping pain in his calves, which goes away when he stops to rest and is sometimes worse at night and when walking on an incline. He has a 40-pack year smoking history and takes 80 milligrams of atorvastatin. On examination, you note weak posterior tibial and absent dorsalis pedis ulcers, and an ulcer on the tip of the right helix with a punched out appearance. What is the single most appropriate examination, investigation? I think everybody's got tired.
ABPI.
Sorry, it's ankle brachial pressure index. The patient is developing peripheral artery disease. The symptoms are characteristic with the peripheral artery. See, he's a smoker. 40 pack per year history is there, and he has cramping pain in his calves, which comes and goes, and it's when he stops to rest, which goes away when he rests. So this is something of the peripheral artery disease, and this is the investigation, appropriate investigation. A lipid profile is useful too, but probably less important since he is already on a max dose of atorvastatin, and the only benefit for lipids is to encourage him to eat more healthy to avoid bursting of PAD, peripheral artery disease. All right, would be more useful to get the diagnosis right. So ankle brachial pressure index would be most important to get the diagnosis right, and for further imaging and surgery if required. Okay. Okay. Just a minute. A 6-week-old baby is noted to vomit after having feed. It is non-bilious, okay, and the baby takes vomits immediately after feeding. So it's non-bilious vomits immediately after feed. On examination, palpable mass at the right costral margin. Now, can you make a diagnosis on this?
It's hypochloremic metabolic alkalosis, and it's pyloric stenosis.
Right. Exactly. So it is pyloric stenosis when there is hypertrophy of the muscle surrounding the pyloric sphincter. It presents between 3 to 6 weeks of life with projectile vomiting, which does not contain bile. Okay. Now, a 38-year-old man is brought to the ER by ambulance after collapsing while out jogging. He was jogging for 20 minutes when the incident occurred. He has no recollection of or warning symptoms prior to the collapse and denies any injuries. He was not confused afterwards. He is unsure of how long he was unconscious. And the first thing he remembers is being loaded onto a bag of the ambulance. He has no past medical history and is usually very fit and active. Most appropriate investigation, what would you do? Shall I proceed with the answer?
Standing blood pressure.
Why would you do a standing blood pressure? What do you have in mind?
No, I guess it's not postural hypertension. It might be
because it was for
urinary
20.
Yeah, for 20 minutes.
It is going to be ECG because looking for arrhythmia, any arrhythmia. First, it will be the first investigation. EEG would take about roughly 6 months, and standing BP is not helpful since the postural hypotension is unlikely.
Okay, that completely makes sense. Yeah.
Now, the last one. A 36-year-old man is brought to the emergency department by police after he was found sitting in the street unaware of his surroundings. Okay. The patient unable to recall his name, date of birth, or home address. His vitals are unremarkable. On examination, he has multiple bruises on his face, arms, and torso. He's unsteady on walking, appears to have urinated on himself. Lateral nystagmus is also noted in both eyes. Now, he has mild gynecomastia and palmar erythema. What is the most likely diagnosis? See, what do you think it is? I gave you this sort of a scenario when we were doing something, some other question, the same sort. Yeah. Yes, it is C. It is Wernicke's encephalopathy. This is patient has unsteady gait. He's basically an alcoholic. Okay. And these are symptoms of Wernicke's encephalopathy, ophthalmoplegia, nystagmus or lateral rectus paralysis, and confusion. Treatment is IV thiamine. There is no evidence of normal pressure hydrocephalus. One episode of loss of urine control when drunk doesn't mean you have urine incontinence. Okay. He's an alcoholic, and that's the reason he's doing like this. So if it is Wernicke's encephalopathy, and in some cases there could be a treatment option given, so then it is IV thiamine. Okay. So we are done with 90 questions, and we will be carrying on with the rest of the questions from day after tomorrow in the paid groups.
Thank you.
Thank you. Okay.
Thank you.
Thank you.
Bye-bye. Bye-bye. By the way, how was it? Did you like, guys? I wanted to go on more, discuss more, but because of the time, I couldn't do much. There were many things I wanted to cover, but I was not able to. So, did you guys enjoy it?
Yeah. Yeah, I did, but towards the end, it was too fast.
Yeah, I know that. It was really fast at the end.
Point,
I couldn't help
wasn't
it.
following.
Okay, I'm really sorry.